Hi, everyone, and welcome back to Emerge Live. My name is Laura Barger, and I'm the Chief Marketing Officer at the Financial Health Network. It's day 3 of what has already been an incredible week of content, and we're excited to get started. For those of you who were with us yesterday, we're so happy to see you back. If you're tuning in for the first time today, thanks so much for joining us. During our sessions yesterday, we discussed topics related to stabilizing our communities during and after times of crisis. We heard themes around opportunities for community leaders to work with private and public sectors to develop solutions for our most vulnerable populations. We heard about the power of partnering fintechs with nonprofit providers to spur community-focused innovation. We also heard a tremendous amount of optimism around our opportunities to meet our communities where they are and adapt existing models to help our frontline coaches and providers make a measurable impact in our communities. If you weren't able to tune in yesterday, we have a recording of the day, as well as Monday's sessions, available right on the page in our related content section. Today's focus is on the explicit connections between health and financial well-being. We are seeing these connections play out in real time as we face the realities of the pandemic, including the tremendous impact that equitable access to healthcare has on the ability for vulnerable populations to weather the health and economic shocks of illness. Our sessions today will feature some of the most forward-thinking experts across health and financial well-being as they make these important connections. Before we begin, here are a few housekeeping tips to keep you engaged and help you get the most out of today. If you're watching today's live stream from the Emerge Live website, please take a moment to check out the related content that we've highlighted on today's page. It will give you some additional context to the topics that we discussed today and a way to follow up for more information. We've also included a live chat function that will be enabled throughout the day. You can see the chat box right here at the Emerge Live page. Feel free to engage in the discussion and ask questions throughout the day. But please note that while some sessions might be able to take questions right away, others may not. We will do our best to answer everything that we can. Closed captioning is available throughout the entire week, provided by the World Institute on Disability. Please see the link above the schedule to access this feature. If you're joining us as part of a Financial Health Network member organization, we will be hosting exclusive networking opportunities at the end of our programming today, tomorrow, and Friday. To register for a session, please click on the Backstage Access link at the bottom of this page to sign up. We have fun and serious topics, so go ahead and take your pick. And finally, please let us know what you think. You'll find a link to our daily survey just above the schedule on this page. Your feedback will help us continue to deliver great experiences to all of you. We hope that today's sessions will spark ideas and conversations in your homes, in your workplaces, and across your networks. Please feel free to share your thoughts on social media and encourage your friends and coworkers to join us today and through the rest of the week. Thank you again to our incredible sponsors who have continued to support these important conversations. Thank you to our diamond sponsors, JPMorgan Chase and Prudential Financial, our financial health sponsor, the MetLife Foundation, our gold sponsors, AARP Foundation, BlackRock, PayPal, and Wells Fargo, our silver sponsors, Bank of America, Intuit, and Fifth Third Bank, our bronze sponsors, Capital One, Marcus by Goldman Sachs, Members Development Society Company, the National Credit Union Foundation, and Opportune. Our day begins with a timely conversation on the disproportionate impact that the COVID-19 pandemic has had on underserved communities. Thank you again for being here, and I sincerely hope that you enjoy the day.
Good morning. I'm Adrienne White-Faines, and I'm honored to be here today to moderate our panel on understanding the disproportionate impact of COVID-19 on underserved communities. Just 5 months ago, as the virus moved into the waterways of the US, for many in healthcare, the COVID-19 was like the Titanic. And the question was not, will it hit the proverbial iceberg of health disparities in the US? Instead, the question was just how devastating will the casualties be when it hits this iceberg? So today we're honored to have an outstanding panel of healthcare experts to share not only what is this iceberg, but also why is it so unavoidable in this pandemic and given our US healthcare system today. And further, we want to highlight how, with more collaborative approaches, we can begin to dismantle and hopefully destroy this massive iceberg to clear a more equitable and unobstructed path of healthcare, both physical wellness and financial health, for populations all across the US. So I'm honored today to be joined by an outstanding panel, and to maximize our time, we're going to jump right in and hear from our panelists. I'm going to refrain from providing more detailed individual bios and ask that you please reference them anytime on the Emerge website if you haven't already done so. So to begin with, Dr. Donald Schwartz is a Senior Vice President for Programs at the Robert Wood Johnson Foundation. And just prior to taking this role, he was Deputy Mayor for Health and Opportunities and the Health Commissioner for the City of Philadelphia. And in that role, and prior to that role, he also has served in leadership positions in academic medicine, in pediatrics and adolescent medicine, at Perelman School of Medicine at the University of Pennsylvania and at the Children's Hospital of Philadelphia. Don, as a physician and as a public health professional invested in creating a culture of health in this country, can you begin by sharing your initial reactions and observations about the onset and outcomes of COVID-19, especially regarding its impact on vulnerable populations?
Thanks, Adrienne. I have to say that we have been very well aware that if I talk particularly about Blacks or African Americans in this country, there have been a series of what have been called social determinants, factors that affect the health of groups in our country who are have less access, particularly to economic benefits. And we know that for Blacks and African Americans, what that has meant is that they are twice as likely to die than whites in general over time.
We're starting to freeze a little bit, Don. Don, we're frozen. I'm going to. I think
that's the most likely to related diseases: hypertension. Hypertension.
So Don, we're freezing. I think what we're going to do is see if we can't get you back, and then maybe move to our next panelist. Let me see. Donna, can you hear me? Okay. So if you will, we're going to circle back and get Dr. Schwartz in on this conversation. But in the interim, while we're straightening out the Wi-Fi, I want to turn to our panelist, Dr. Brandy Kelly-Price. And Dr. Kelly-Price, you currently serve as the Director of Programs at the Humana Foundation in Louisville, Kentucky, and you direct the foundation's health equity research and strategy for their $65 million in investments. So before joining the foundation, you were also the director of the Louisville Metro Center for Health Equity, with a joint appointment at the University of Louisville School of Public Health, where you still teach, and advancing your scholarly work on the intersections of health equity and social impact. Brandy, from your lens, and can you share your initial thoughts, and then we'll circle back to Dr. Schwartz.
Thank you so much, Adrienne. And, I'm really excited to be on this panel because I think initially what I was thinking about COVID-19 is that I am so excited in some ways that we are going to have an honest conversation in our country as it relates to the social determinants of health. It is a devastating disease that has ravaged our world, a devastating virus that has ravaged our world, and even economically has created upheaval. But as we've seen over the past 3 months, as it relates to the virus, as well as it relates to police and brutality in our country, there has been a systemic issue. Structurally, structurally, we have faced an issue throughout the starting of this country for African Americans and Blacks, as well as Black individuals in our country, as well as for other people of color, whether that be our indigenous populations, our Asian Americans, or our Latinx populations. And so where we're seeing the disparities, particularly among the mortality rates as it relates to COVID-19, is not surprising. I think what has been surprising, and it's not surprising because of our life expectancy gap. It is not surprising because of our morbidity and mortality rates due to diabetes and respiratory and heart disease throughout the country. So, I think that's what we were hearing a little bit from Don in terms of those actual numbers as it relates to the disparities. And this was happening well before COVID-19 hit, and obviously is going to be exacerbated through the pandemic. One of the things that I think is really nuanced about this moment, though, that I want to make clear is that we are seeing a structural issue, not as it relates to race, but as it relates to racism. So it is the context in which people are engaging in the structures around them. There is not a genetic factor or a biological factor that creates the color. The color of my melanin is not connected to my biology, so to speak. And so what we really have to consider is, how are we going to have a hard conversation or address the hard truths in America in terms of the impact of how someone interacts with their structures or with their systems around them, whether that be police, the healthcare system, the economic system, and the racial wealth gap that we're seeing. And that racial wealth gap has been building over time. It is, I know we'll get further into it in terms of the conversation, but when we're really looking at this issue, not only are we talking about what is going to be the impact on life years lived and quality of life, but we're also talking about what is the economic upheaval in communities. And when before we were seeing probably about 17%, or when we were seeing ownership for the different racial groups, I'll just use the Black and white racial gap as an example. There's been a 17% loss in white ownership in terms of businesses. There's been over 40% loss in Black ownership in businesses. And so how is that really impacting the financial health of not only that individual, but their communities as a whole? So I'll stop there for now.
Wonderful, thank you so much. And you've given us some meat, and we're gonna go into many of these issues in just a moment. I'm gonna jump back and see if Don Schwartz is available. Don, can you speak up now? Are you on mute or? Okay. Looks like we might still have a freezing issue. Okay, so let me continue on and go ahead and introduce our third panelist. Our third panelist is also, as I'm here in Chicago, I'm pleased to introduce Darlene Hightower, who also viewed the pandemic from the eye of the storm here in Chicago while she serves at Rush University Health System, where she's a vice president for community health equity and engagement. With oversight in that role, she has oversight of implementation and evaluation of community programs, including school-based health clinics and community outreach programs, such as the Cradle to Career Healthcare Pipeline. She has extensive involvement in a variety of community activities in underserved communities in Chicago, and also was recently named as the Robert Wood Johnson Foundation's Culture of Health Leadership Fellow. So, Darlene, can you jump right in here and share your initial thoughts and perspective with us on COVID-19?
Sure, happy to, Adrian. Thank you for that introduction. So I want to bring a little bit of local numbers and flavor to this conversation. Here in Chicago, we've had about 2,500 deaths from COVID-19. I just looked at the data today from the Chicago Department of Public Health. 75% of those deaths have been African Americans or Latinx residents in Chicago. We talked a lot about that not being surprising, that these communities are hardest hit. What I'd argue, though, is that it's unacceptable. Like, we've known for years that Black and brown communities are vulnerable when it comes to economic investment, educational outcomes, health outcomes. So no, the fact that COVID-19 has hit these communities hardest is not surprising at all. The fact that we allow this kind of stuff to continue to happen, that is what's shameful. So I talked a little bit about death rates, but when we talk about incident rates, and when you look at January to date, the Latinx population has gotten COVID-19 at rates that are twice as high as everyone else in this city. Again, why is that happening? What is it that we're going to do about it? I think now there's an opportunity for us to finally do a deeper dive into what Don was initially starting to talk about, the social determinants of health. Because from my perspective, these communities are vulnerable and we have poor health outcomes because of poverty. And I'll just be bold and say poverty kills. We know for a fact that higher educational attainment, higher quality jobs, and higher incomes means that you will have higher or better health outcomes overall. So if we know that to be true, what are we doing as a city, as a state, as a country to get at the economic and educational factors that are causing the type of health disparities that we're seeing now? Because the reality is, yes, we're going through a pandemic right now, hasn't happened in the last 100 years, but in Chicago, we also went through the 1995 heat wave. Who died from that? Poor African-American people in vulnerable communities. We went through the AIDS crisis in the 80s. Who died from that? People of color died from that as well. So we're seeing history repeat itself just in a different form. Now is an opportunity for us to address it and be honest and real about why these populations are continuing to suffer from disease at higher rates than others. And I'll stop there.
No, thank you so much, Darlene. We're going to have a lot of meat for our conversation. Don Schwartz, can you chime in?
I'm going to try to. Let's see if that works.
Yes.
I have been trying to figure out what to do about connectivity issues. I apologize.
No worries.
So the only thing I would add, I think my colleagues have very nicely summarized. What we have seen that is not terribly surprising is just how disproportionate things have been. So we know, for instance, that in terms of folks on Medicare, there's 4 times the number of African Americans being hospitalized in terms of a rate of hospitalization compared to others. And that disproportionality goes across all aspects of healthcare need. But unfortunately, we also know that healthcare insurance has not met need. So because African Americans and Blacks particularly have been employed in essential services, they are being put at risk. But those who are African American or Black who have been employed in those services have been much less likely to be covered by insurance or eligible for insurance when they lose the job. And so we have a lot of folks who are particularly at risk and particularly ill who don't have access at the moment to insurance. We're even more worried that we're seeing rises in rates of people who are uninsured without a good response to help provide people with that insurance. And it's even worse if folks live in states that haven't expanded Medicaid, which we can talk more about later. Thank you for your patience.
No worries, no worries. What I'd like to do now is actually take this just a layer deeper. So you all have done a terrific job of giving us a wonderful and broad overview. You've mentioned things about access, insurance. You've mentioned issues on income and neighborhood designation and the results of segregation. We've mentioned racism. We've mentioned issues around need for services. So let's take this one step further. And I'm going to start with Darlene. So Darlene, you know, the data has indicated that the impact of COVID-19, some of the possible causes are likely to be further exacerbated because those that were hit were essential workers, particularly in minority and underserved communities. What the real reference here is that there was a real economic hit and a real tie between financial equity and health equity. Can you highlight what your learnings are and what you'd like to share with us about the issues of employment, workforce, income, et cetera, and its impact on health outcomes?
Sure. So as you were talking, one of the things that came to mind is most of us were under shelter-in-place orders beginning in March. And they're just recently starting to lift here in Chicago. And if you were fortunate enough to have a job where you could work from home, it was inconvenient, you know, but you took your laptop and you carried on and you did the work that you had to do. But that's a privilege. And not everybody has that ability to be able to work from home and use a laptop and still be productive and get things done. What we found is that a lot of people of color, both Black and brown, did not have that privilege, did not have the ability to be able to stay at home and shelter in place. They had to get up every day and go to work. They were bus drivers, or they worked in places where they had to get on public transportation to do essential, what we call essential work. And so you're seeing differences in economics and then therefore differences in who's being affected by COVID, because some people did not have the ability to stay at home, to shelter in place. They had to be out. And so then it's not necessarily surprising that as a result of that, because people were out and, you know, exposed and basically just trying to earn a living, that they are then vulnerable and suffering from incidents of COVID-19 at rates that are higher than others.
Thank you. Thank you. I'm going to ask Don to pick up from there and talk to us, you know, go back to your experiences from Philadelphia as the Commissioner of Health, and, you know, talk to me about the life expectancy gaps and how that begins to, how zip code can determine your ability to succeed, survive, or thrive when a pandemic such as this hits.
Yeah, thanks very much. I have been aware for a long time of the disproportionality in terms of life expectancy in cities like Philadelphia. Philly is the poorest of the largest cities in the country. And so that set of impacts that come from poverty in the city and poverty in places in the city disproportionately affect the health of people. So if you're an African-American man in Philadelphia, your life expectancy is on average 25 years less than, for instance, an Asian woman. It's enormous. And if we look by neighborhood, so downtown in the central part of Philadelphia, which is largely white and largely affluent, people live on average 87 years. And in North Philadelphia, which is largely folks of color who are poor, the average life expectancy is 64 years. Mm-hmm. So disparities are huge. And we know that place makes a difference. So where you live affects what you eat, what transportation you have, where you go to school. It's fundamental in this country. And we're seeing that play out everywhere in terms of COVID. So for instance, in the counties in this country where the largest proportion of people who are African American live, those counties are places with the highest rates of COVID deaths. The impact of place and all that place means both for policy and for access and for the impacts on health and the ability to be healthy, it's profound, and it plays out in Philly as it does, I know, in Chicago and the other places that folks who are part of the panel live in.
And Don, to that point, I mean, what many often forget is that those places, those zip codes, those locations are actually were intentionally designed many decades ago to steer those communities to those zip codes. Therein lies, they began to grow and fester and create the very disparities that you speak of. But it wasn't that people chose to end up there. So Brandy, can you jump in? You know, one of the things that's happening is in this discourse, in this elevated visibility of disparities and the challenges of health inequity, we're also finding ourselves in the midst of a massive visible display of the impact of racism on populations. And the connection between our healthcare institutions and the identified systemic racism is bringing forward many providers to come out and proclaim that systemic racism is actually a public health crisis in and of itself. Can you talk to us more about how this is and what are the ties that the healthcare community makes around these types of issues? And maybe Darlene, you want to jump in after, because I know your institution signed on to such documentation. Brandy, can you pick it up for me?
Sure. Well, thank you. You know, and I want to, I think it's really interesting when we think about how public health is making this stance right now. So we hear that from the American Medical Association, the American Pediatrics Association. And so thinking about, you know, this is affecting our children, no matter what race of the child, this is affecting and has affected the life expectancy of individuals since, as I said before, since the starting of this country. It's really amazing to see some of the early writings before the 1900s by Black physicians that were talking about the impact of not only slavery, but the impact of racial inequities on the life expectancy of African American individuals in this country. So I don't think it's a new dynamic, and I think this is something that we're actually saying. Working at the Humana Foundation, so we're the 501c3 arm of Humana Inc., we do take a stance of being an anti-racist organization. We are very clear of how we want to co-create with communities. We're very clear that we need to disaggregate our data by the different communities that we're serving, and let's really try to systemically address the inequity in that community. Because as you said before, Darlene, we know that this is not something that has just come to be. This was an intentionally created issue in our structure of our country when we're talking about the policies and the ways in which places were designed and constructed. We see everything from redlining that happened in communities all throughout the country in terms of how banks and grocery stores are deciding where they're going to go today based off of some of those maps that were legally put into place back in the 30s. The GI Bill, the evictions, the exclusion, all of these are policies that come into place. And so when Don is talking about place matters and zip code matters, what we also know as it relates to racial inequities is what Brookings put out, probably back 2016. They talked about the multi-dimensions of poverty, or the multidimensionality of it. And so it's not just income, as often, having conversations about poverty, it also oftentimes would get conflated with just one being low income. But it is a matter of, may choose 5 dimensions, but having health insurance was one of those, in terms of, are you able to pay for your health care? And even living in an area where there are 20% or more who are living below the federal poverty line. So I might have the highest income, I might have health insurance, I might have opportunity for home ownership, but because of the area itself and that access within that area and the other individuals who do not also have high wealth, that is going to cause a lower rate of economic and financial growth for me as well. So I think, we need to have this very holistic conversation, and that is one of the conversations that we are having at the Humana Foundation in terms of the investments that we're making, knowing that it has an impact on not only someone's lifelong years or their life expectancy, but how healthy is their day going to be today.
Yeah,
Absolutely.
I'm just like
right.
chomping
Darlene,
at the bit to jump
go ahead,
in on
Darlene.
this. Because I've been thinking so much about what you just mentioned. A couple of folks have mentioned about redlining, and how that has such an impact on health outcomes. So this is a practice that started in the 1930s and legally ended in the 60s, right? You're not supposed to redline neighborhoods as bad or good and then base economic investments on them. But the reality is that that is still happening today. There was an article that came out with the WBEZ that looked at who's lending in these neighborhoods from 2012 to 2018 in the Chicagoland area. And what it found was that 68.1% of the dollars that were loaned for housing purchases went to majority white neighborhoods, while just 8.1% went to majority Black neighborhoods. And what that means is that for every dollar invested in white neighborhoods, only 12 cents was invested in Black neighborhoods. And that matters, like mortgages and home ownership, as Brandy said, it matters because that dictates if you've got businesses in your neighborhood, viable businesses, viable grocery stores, is your community walkable? All of the things that we know make for a healthy, vibrant life. So the redlining thing is real. It continues to impact our neighborhoods. I can talk about what we're doing about it, but I'll stop.
I'm gonna hit you with that just a minute.
Okay.
Don, I saw you nodding your head. Did you want to jump in on this conversation? Is this every time I call up poor Don, he freezes. Okay, we're going to circle back and jump right now. Darlene, you talked about solutions. And I think the one thing that we all are learning is, as we go through these very difficult times, it is essential that we learn from these times so that we not make the same mistakes and carry on and perpetuate the inequities. Talk to me, all of you, as I circle through, to share some of the things you are doing with your organizations. And I think we'll start, Brandy, why don't we start with you?
Sure. So, as I mentioned, we were making investments in the social determinants, and really being clear in terms of that everybody is experiencing some determinant of their health. It is not only those who are experiencing poor health. So we were investing in those before the start of COVID-19 in 4 particular areas: food security, employment and income, financial asset security, and education. And then one that I think is, all of them excite me, but one that really has me interested in how do we actually get to what we're trying to change in our country, the actual determinant of our health, is the social connectedness, and how are we shifting the landscape of our communities based off of a citizenry and who is connected and how can they be connected, and why. And so those are our 4 areas that we focus on. But I think more specifically, since COVID-19 hit, it was exciting to have a gift from Humana Inc. to the foundation and to work in partnership in terms of what are we going to do to address what needs to happen now in communities. And that is everything, as I was talking about before, from building deeper level infrastructure. I know our parent company has invested in the infrastructure of a zip code in our community here in Louisville, our hometown, in terms of where the Louisville Urban League is building a learning and track complex and a $50 million project to really help to raise the infrastructure of the community. And so we, as the foundation, we've come alongside and we're saying, we know that poverty is more than just about one's income, but we are really going to work on workforce development. We are really wanting to build the trust and transparency in the way in which we talk about living wages in our community. So we've supported the National Domestic Workers Alliance, and we are really thinking about One Fair Wage as also a partner that we wanted to invest in. And I think prior to that, we were intentionally investing in our Metro United Way that had a financial literacy program. It goes so much further than financial literacy, in education. But what Metro United Way was doing, which I think is really our systems level change that we're pushing for, is how do we have greater context around the census and really doing advocacy efforts in terms of what money is lost in a community when there are certain individuals that are not counted in that community. And so that is one of our systems level change that we have in our partner Metro United Way with their XLU rate program. So I'm really looking forward to us going deeper. We have not changed it yet, and nor will we change systemic and structural racism with philanthropic dollars. It is going to take a multi-sectored approach, but I'm enthusiastic about the path that we can be on when we're really willing to face the reality of where we've come to this moment and who has been privileged to get here and who was not.
Great, thank you. Don, I see you moving, so I'm going to grab this moment. Lots I'm sure you want to say. I'm just going to let you jump right in.
I'll try to be quick. I apologize for the instability. I will say that the Robert Wood Johnson Foundation has been focused on this whole area of social determinants now for almost 6 years. And so when COVID hit, it was a good time for us to double down. We've done things that may be unexpected for a health foundation, like we're increasing the number of guarantees that we're willing to provide to institutions that are helping to assure that African American and Latino-owned small businesses don't go out of business with bridge dollars. We're supporting institutions that are helping folks think about how do we bring affordable housing to places that may have been the subject of redlining, so that people can, in this moment, do what's necessary to assure that affordability increases. We're doing a lot of work that we've done for a long time on health insurance. We're aware that at the moment, if you become uninsured in a state that hasn't expanded Medicaid, you are almost twice as likely to stay uninsured. Medicaid expansion has substantially both reduced the likelihood of uninsurance, and it has improved the health status of people in the states where it has occurred. And at this moment, it is an essential service, a financial service for people, because those who get COVID and require healthcare services in states without expansion, those folks are going to be hit with healthcare bills. And those bills are going to go unpaid if they don't have a job and a financial resource, and their credit will be affected. It will affect all of us, and it will only make the health status of people in communities already challenged that much worse.
Before I flip over to Darlene, I just want to engage Don. You, Brandy, mentioned a conversation about the importance of data. And as we talk about the integration of financial platforms for equity and health, one of the things that COVID did reveal is how replete we are in this country of really understanding how to integrate appropriate data. Can you just give us a tidbit And then I'm going to let Darlene close us out.
I can just say that we are mightily investing, and we are partnering. Although people are not happy with the CDC is working very hard with states and others to try to use this moment to improve both the data availability so that when new waves of COVID hit, we're ready. And it's also focused on helping states report by disaggregated categories so that we can track the epidemic among people who are most impacted, who did not get identified well in the early stages of COVID.
Yes. So Darlene, you're deep in this work and have done some amazing things for the West Side of Chicago. Share with us your views, your vision. What do we all need to know about what it takes to make this a success going forward?
That's a really great question. And as everyone was talking, I'm thinking to myself how big and intractable these challenges and issues are. We're talking about things like poverty and economic disparities, these like structural things. And when you look at it from that perspective, it can feel daunting. But my advice to any organization or people that are watching is to use what's in your hands. What is available to you right now as an institution, an organization, an individual to be able to help. And so for Rush, we are the largest private employer on the West Side of Chicago. We've been on the West Side for 180 years. We're an economic engine. And 5 to 6 years ago, we woke up to how do we use that economic engine to really positively impact our West Side neighbors. And what we've done is kind of claimed our anchor mission or our anchor status by putting in place an anchor mission where we are hiring locally and developing career paths when people come into our doors as employees. We are, when we build buildings and other capital projects, making sure that there's a local presence and who's working on those projects. When we're buying things, which, we have a big supply chain, making sure that the folks that are in that supply chain are small businesses from the West Side. We've been doing social impact investing. So taking a look at what are the economic development projects that are happening on the West Side and how can we invest in them through CDFIs. And then lastly, how are we marshaling our employees? We have 13,000 of them and investing their time, talent, and treasure intentionally on the West Side. So that's what we're doing as an institution. And the last thing I'll mention is we were one of the catalysts for an organization called West Side United, which brings together 5 other health institutions that are also wearing their anchor mission hats and doing the same kind of buy local, social impact investing, hire local, and career pathways.
You all are an absolutely outstanding panel, and I can't thank you enough for your cooperation and fluidity to get us through this conversation. America, as you know, is reeling right now from multiple crises. But as each one of you have pointed out, this is a unique time to say no more. And let's take innovation, let's take collaboration, let's work across channels, let's be disruptive, and let's come together to see if we can't break this iceberg down once and for all. Thank you, all of you, and thank you, Emerge, for the opportunity for this wonderful conversation.
Hello, everyone. and welcome to our panel discussion from the employer perspective as we explore health and wealth in the workplace. I'm Nancy Vitale, and I am the co-founder and managing partner of Partners for Wellbeing. We are a boutique consulting firm that's dedicated to helping organizations integrate well-being into company culture. And I have spent the bulk of my career in human resources leadership roles in a variety of industries. And I recognize that these are unprecedented times that we are all navigating through, with a global pandemic, an economic downturn, and civil and social unrest that is gripping many communities across our nation. And with all of this, it puts an immense amount of pressure on employers. Employers who pre-COVID were the most trusted institution, according to the Edelman Trust Index. But during COVID, that trust has eroded a bit. And employers carry a significant responsibility to provide for the well-being of the people in their care. We're going to be exploring two facets of well-being, physical health and financial health, with the esteemed panel that's joining me today. But before I have them introduce themselves, I just invite our audience members to please engage with the chat function on your screen. We'd love to try to get to as many of your questions as we possibly can in the time that we have. And for now, I'm going to ask each panelist to very briefly introduce themselves and why they're passionate about this topic. So Sherry, I'll start with you.
Great. Thank you, Nancy. So my name is Sherry Olson, and I have interest in the financial health industry. Personally and professionally, I have over 20 years of HR experience in the SaaS technology and financial services industry, and have been providing health policies and programs to employees to help them with health and wealth needs, to support them throughout their life stages. I currently work at a company called WEX, and I'm fortunate to lead human resources within our health division. And I'm so proud of the work that we've been doing around consumer-facing research to help educate employees and consumers on how they can save and pay for healthcare with tax-advantaged benefit programs. One thing we've learned is that millions of Americans are missing out on benefits that can help them pay for their healthcare costs, and we do have an obligation as employers to help create that awareness, educate, as well as empower consumers. And so at WEX, we've adopted financial health as a top priority that I'll be sharing more with you today.
Thanks, Sherry. Cheryl, how about you?
Hi, I'm Cheryl Simmons. I am the CEO of Three Flights HR, an advisory firm that focuses on creating high performance cultures by connecting people strategy to business strategy. I've spent many years in executive and C-level HR roles, working with businesses throughout the US and Europe, most recently as the CHRO of Maestro Health. During my speaking engagements in 2018, I mentioned multiple times my prediction that in the coming 12 to 18 months, that financial wellness would become as relevant as physical and mental wellness. And here we are, and that was a pre-COVID prediction. I believe there is absolutely a connection between physical, mental, and financial health, and that we must engage in all three areas to address the whole health of our workforce.
Thanks, Cheryl. Robin?
Yes, hi everyone. I'm Robin Likens. I'm the Chief People Officer at Opportune, and I've been in the human resources leadership field for over 25 years. Started my career in retail and also worked in a variety of different technology companies and now in financial tech. For those of you who are not familiar with Opportune, I have the great honor of working for this amazing company. It's a high growth, mission-driven CDFI company, and we employ over 3,000 employees globally. Our workforce is made up of primarily retail and call center employees, but we also now have a growing technology organization. And I am really passionate about the topic of financial health because I've seen the positive impact that our company has had on our customers. And I've also had the opportunity to serve on a nonprofit board in which we were able to do coaching, career planning for underserved communities. And so putting these two together has really made me see the holistic person in terms of end-to-end life cycle of the employee and how important this aspect of both health, financially and physically is so important to the well-being of your employees and being able to make your company so much more productive and healthy.
Thanks, Robin. Mary?
Hi, everybody. I'm Mary Kane. I am a public health person by training. That's my background. And I've spent about 20 years building out chronic disease management programs for employers and health plans. And also working on integrating medical care, insurance benefits into the broader well-being for a population. So thinking about it from a total population health perspective. I'm currently in charge of clinical product at Castlight Health. And at that organization, at Castlight, we focus on trying to make it as easy as humanly possible for people to navigate the complexity of health and healthcare benefits. We do that by bringing together massive amounts of data to create a comprehensive profile and then create personalized recommendations for each person that link all of their benefits to them and make them all available to them as easily as possible.
That's great. Thanks, Mary. And I'm actually going to pose the first question to you. Given just your role and the amount of data that you have seen, is there any evidence that you've seen linking physical health and financial health as we get this conversation going? And, what data insights or patterns perhaps might be helpful for us to understand as we get into this notion of the role employers play and the things they should be paying attention to?
Yeah, so one experiment that we've seen over the past decade that's been playing out specifically in commercially insured populations, commercially, self-insured employer populations, is high deductible health plans. So these are health plans where the employee pays out of their own pocket for the first few $1,000s before their insurance kicks in. And we know that people behave differently with regard to their access to healthcare depending upon where they fit in the wage strata. So if they've got a high deductible health plan, they can be in the same employer, same community, same benefits. And what we've seen is that if people are in a high wage category, they behave differently than people in a low wage category. For example, people in lower wage categories are more likely to delay necessary healthcare services, in particular, preventive healthcare services. We see low wage employees get 50% of preventive care. They have 4 times the numbers of avoidable hospital admissions. They have 3 times the numbers of emergency room visits when you compare them to higher wage employees. And the opportunity here from an employer perspective is to think about what can we do that can help people not delay that care? How can we help people think about continuing to get that preventive care? So the most natural thing to do is think about benefit design and the impact of high deductible health plans on that people making the trade-off of where the money is coming from and what else they'll have to prevent, or rather they'll have to give up in order to get that necessary health care.
That's fascinating. I mean, you've raised a number of important considerations from an employer perspective as we think about that wage stratification and how to then think about incentivizing or the behavior that you seek in terms of making sure those low wage earners are getting the health care that they actually need. Sherry, do you have anything that you want to maybe add to this, given your perspective?
Yeah, and so just to add on to where Mary was going, we find that if folks are financially healthy, we see that direct correlation between the quality of their life and the physical well-being. If we struggle financially, we also tend to see higher rates of anxiety, stress, and people tend to not seek that treatment due to the health issues. And so if it's not addressed, those critical health issues, it's compounded, which leads then to more serious illnesses, which then only perpetuates the financial issues. And so it certainly is a full vicious circle. Through the research that my company WEX has conducted, it was a study last year called Paying for Healthcare in America. It goes completely to the point that Mary was taking, which is people are stressed out. In fact, twice as many employees are stressed out about their finances than about their jobs. And so when we think about the implications, the financial stress is worse than stress over health concerns and relationships combined. And so that could mean that there's more people lying awake at night about the cost of expense, thinking, I have a $1,500 deductible, but only $300 in the bank, and worrying about how they're going to pay for those healthcare expenses. They're more concerned than possibly having a healthcare event that could impact their well-being. And so of concern, it's interesting because in the study, 25% of the workers also stated that they will forego healthcare services associated to any out-of-pocket expenses. From an employer standpoint, it gets alarming because those workers, if not taking care of the critical issues, have productivity engagement issues at work, which can lead to distractions, calling out of work because they're sick, doing possibly little work, or possibly even leaving work early. And so from an employer standpoint and HR standpoint, we just need to be paying attention to people's holistic lives. And I believe we have a responsibility to help employees manage their finances, which helps our culture, helps boost productivity, revenue, as well as increase retention rates.
Thanks, Sherry. A lot of factors to manage from a trade-off perspective as you think about the engagement and health and well-being of the workforce that are in your employ. Thanks for those comments. Cheryl, I'd like to bring you into the conversation. And I'm curious, if you've seen any demographic, social economic differences, as Mary and Sherry were alluding to, that create or contribute to the negative impacts on financial and physical health.
Absolutely. There are most definitely differences that contribute. Social determinants play a crucial role in the overall wellness of an individual. And we all know that there are significant inequities in societal resources. So an example would be, let's think of an area with a food desert. People living there have to travel further and pay more to just get basic healthy food. So travel further and pay more is most definitely a negative impact. If you lack transportation, you're forced to buy local. If local means no fresh or healthy food options, you just started that physical, mental health, spin cycle. The US, despite spending far more on medical care than any other country in the world, continues to have poorer health outcomes than most other developed countries. There's a reason for that. But I think we also need to understand that financial health it's not a one-size-fits-all model. It isn't a specific number. It's about how each person defines financial security and having the financial freedom to make positive choices in their demographic, social, and economic circumstances. Everyone's journey is going to be unique to their situation. But of course, there are common traits, things like meeting your everyday needs and obligations, having emergency funds, that safety net that we talk about, getting out of bad debt, goal planning, but even starting with the very basics of budgeting. These are skills that so many people have never had the opportunity to learn. So yes, there are definitely differences that contribute.
Right. Thank you. Mary, anything to add? Because I know you have some interesting perspectives on social determinants.
Yeah. So we've been looking at social determinants here, and I think it's interesting because it has been something that's been so much a part of public insurance and public programs, and much less something that employers have focused on. So I think there's an opportunity for employers to be thinking about how to target different parts of their population to help people overcome what might be perceived as a stigma associated with social determinants of health and needs there. Some employers are starting to pay attention to bringing together unique and different sources of information to be able to better target different parts of their population, in particular looking at sources of stress, financial stress obviously being a huge source of stress, but also looking at job structure, amount of time people are able to take off, whether people are working swing shift. And those things that are then contributing on top of, the financial stress are then contributing to poor physical health. And what they're looking to do is really focus differently, again, in the context of benefit design, figuring out ways to seed that HSA if they can, create opportunities for somebody not to spend their own money out of pocket. And then also looking at ways to bring in some of the service providers, or creating a way of normalizing using some of these service providers that have previously only been targeted at publicly insured populations. So, making some of that a little bit more acceptable and reducing some of the stigma that's attached to some of those services. Because as we see in this context, a lot more people are in need of those services right now.
To that end, I'm gonna take an audience question here, and ask, maybe you can start us off, Mary, and if anyone else wants to chime in here. But do you believe the responsibility lies with the employer or with healthcare providers and health insurance companies?
Yeah, it's a great question. So for providers and health insurance companies, these folks are in their catchment area. They're not going to move out of their catchment area. They're going to remain part of their catchment area. And we need to think from the provider perspective, in the context of serving a community, how much you're able to serve that community, what you can do for that community so that community can remain healthy. We're seeing a very strange, if not perverse, experience right now as providers are missing out on some of their income, some of their sources of income, these larger health plans, health providers, and are struggling from a financial, stability perspective because they're not able to do some of the surgeries that would otherwise pay for other services. So that's a really interesting thing from a public health perspective. And then with regard to the employer, again, these people are your employed population. If you want to continue to have these folks be available to you in a productive way and, delivering the services that they're providing, it's not like they're going to move away, right? So I just feel like there's an opportunity really to be thinking about the long game instead of the short game here, and be thinking about how to serve that broader population in the long run.
Yeah, that's great. It's an and both, as with most things.
Yeah,
I
exactly.
think is what you're getting at. So, Robin, I want to bring you into the conversation, and I'm curious, what strategies have you employed to address the financial or physical health of employees, and where might there be overlap in the resource offerings or support that you're providing to employees in addressing these two aspects of well-being, financial and physical health?
Yeah, thanks for asking. So under regular circumstances, beyond the current situation that we're in today, our company has really been focused on providing access to free financial coaching, both to our customers and to our employees through a national program partner that we have. But we've also, on an ongoing basis, offered a variety of different types of webinars to educate our employees on equity as we became a public company last year, and 401k programs, our benefits programs. And then we also have an ongoing employee assistance fund, which is a 501c3 that provides financial assistance for employees that qualify. So these are some of the basics, but one of the things is through this current crisis and thinking about our employee population, many of our employees actually live in the communities with the customers that we actually serve and have been impacted. And in some cases, they are the only person in their family that still has a job. And we're so proud that we have been able to keep these people employed. But some of the things that we've done to address this, both with financial and physical, because it's become even more front of mind, is that we have taken the current programs and really kind of up-leveled those in a way that are more meaningful for today. But a key for us has been to really open up the communication channels and closely track the needs of our employees on a regular basis to understand how they're doing, what they're experiencing in their roles, and how we can help them both, physically and financially, given all the stress and the financial challenges that everybody's facing. So a couple of things that we did that were really focused to help us beyond some of the basics is, after listening, is we really got a good understanding that in order for our employees to continue to come to work and operate specifically in our stores and our call centers, is that we made the decision to provide some assistance for childcare so that our employees, one, could be helped financially, but also take that extra burden off of them in terms of worrying about how they were going to get some help to cover for their children while the schools are no longer in session live. So those are a couple of things that we did. And when you think about both the financial and the physical aspect, the stress and anxiety that's coming through everything that's happening. And, we've really learned a lot through the process, and we're going to continue down this path and continue to keep those lines of communication open. So I think that they go hand in hand. You have to address them together because they do connect, whether it's today or, a year from now. And listening is really the key, and understanding the needs of your employees.
I think that's so important. And in the circles that I've been discussing, with different employers across the globe, this notion of an ongoing employee listening strategy is so key. The frequency of the pulsing of surveys that are going out seems to have really increased through COVID and the crises that we're doing. And then the obligation to do something with that. And then thinking about these two facets of well-being as a focal point. Sherry, what from your perspective?
Yeah, I'd like to highlight a few different areas. One, certainly like Robin, we're very focused on the financial and physical health of our employees. And we have a financial pillar that's centered around employees' well-being. And it includes programs like total compensation, financial rewards. We also include the comprehensive benefit and different community programs. One program in particular that I'd like just to highlight today is that we have a WEX Compassion Fund, which is funded by employees' contributions, our board contributions, and company contributions. And so it has been a very important fund for us because it's provided relief for WEX employees through this unprecedented time to help them with critical financial needs caused by, qualified disasters or other hardships or burdens that they're facing. And so that's been an important program for us, which we developed years ago. We're really seeing the need for it at this point. And then on another aspect, to your point earlier, Nancy, employees do trust employers, and we have an opportunity to really have open dialogue and discuss finances and financial behavior at work. And so we've been spending a lot of time thinking about how do we help employees through budgeting 101 sessions, working with our vendors. We're looking at more sessions around 401k, health savings accounts, flexible spending accounts, dependent care accounts, and other financial health programs. And as we target communications, we're providing a 24/7 financial health advisor with partnership with our vendors. And these have been very popular and I would say overall appreciated programs to help people take care of their financial well-being and then better focus on their careers as well. In addition, just the last point I'd like to make is I'm fortunate because I work within our health division. And so WEX started a National Health Savings Account Awareness Day, which will be again October of 2020. We started it last year and we're looking forward to helping to educate consumers, employees about HSA because we know so many people miss out on the opportunity and there's a greater understanding and a greater dialogue that's needed. And so we're going to be definitely increasing our presence and focus with more consumer-driven stories and messages. And it'll be great just to see it grow in popularity and have more people within the industry involved.
Robin and Sherry, as you guys were articulating these different strategies that you've employed, it made me also wonder about the shift as more organizations have moved to a higher percentage of people in the virtual world. And as we've seen some of the implications of, I think, Robin, you may have mentioned just from a daycare perspective, as you think about the daycare needs of parents kind of shifting, and how does an employer think about providing for those needs differently when a lot of people are working remotely or where you might have essential workers? Are you seeing any other shifts as we think about this, more people working virtually and remotely or from anywhere versus in an office setting, to the financial or perhaps physical health resources and strategies that you're employing?
Yeah, we actually, we went through a big transformation very quickly as part of this pandemic, where we migrated almost 80% of our employees in our call centers to work from home, to work remote. And we had to do that, practically overnight, both for employee safety, but also to comply to some of the local standards in Mexico as part of this crisis. And so what we learned really quickly is that we also needed to teach employees how to work from home. And so we did several sessions. They were very interactive to hear from the employees around some of their challenges and to try to help develop programs and processes and tools to help them be most productive. But I also overlay the childcare aspect of it too, was very helpful, because now you have folks at home working and they have children there, and how are they going to get their work done throughout the day? And so hence the creation of the childcare program.
That's great.
And to add to that, Nancy, I would say on the WEX community side, we've really had to amp up our communication. We similarly had 100% work from home in a week. And so, with 5,000 employees global, that was no small task. Although, we did it with just a lot of leadership support and a lot of care for team members. And the one thing that we've been continuing to do through those, it sometimes has been daily communications, but certainly now we're at a weekly cadence, is a lot of webinars and webcasts where we can, again, start to address some of, again, the tools as well as the financial health and wellness programs that we have available to help people. We're finding that we're seeing with the recent landscape more telemedicine, mental health virtual visits that are very cost effective from an employer standpoint. And this shift in behavior and a workforce that's embracing the flexibility and frankly wants flexibility in the future with virtual sessions, remote working patterns. We've realized that over the past 4 months, it's changed our service and delivery. And we know that we can do this with technology and communications and leadership support.
That's great. Thank you.
Nancy, can I just add one more thing there?
Please, go ahead.
So I would echo the comment about employers really making a huge effort to communicate frequently. I think that's one of the things we're seeing a lot of, and we support some of that on our platform, but on a daily basis, large employers are communicating about COVID and trying to support people working remotely. The other thing that they're trying to figure out how to do, and I think this is related to well-being generally, is how to help people stay connected and feel connected to the organization, and so and remain sane in the context of this complete new reality. And so a lot of what our customers have been asking for is support around engaging people from a well-being perspective. So helping people certainly navigate healthcare and this weird world we're in now as it relates to do you use telehealth, do I need to go in, who do I call? But also thinking about how do I help people be healthy on a daily basis? How do I help people reduce stress? How do I help people exercise? I think the childcare example is a perfect one, where it's like all of a sudden there's a completely new problem that we don't have a solution for. So we definitely see employers jumping in from a kind of broader well-being perspective as well, being something they're looking to solve for.
Yeah, that's a really good point in terms of connected. We actually started what we're calling culture pods, and it's a way of more formally scheduling time for folks to get together, and we're leveraging Zoom to do that. And people can break out into the chat rooms and there's a topic. And we've really seen a really, really good participation. And we're figuring out how to continue to do that, even beyond this COVID crisis, because it's really brought the team together and given them a forum to connect with others that they may have not had a chance to do with that in the past.
That's great. All great perspectives. And at the risk that this may seem a little self-serving, Mary, I'm going to pose this question to you from our audience. How can employers integrate seamless access to financial well-being tools without all the hoops to jump through that can come with opening bank accounts? And others may have a perspective on this as well.
Yeah, this is hard, because I think a lot of financial well-being, and I would actually welcome, you guys know actually a lot more about this than I do, so I would welcome others to jump in here. I think that for a lot of financial wellness, financial well-being services, they're not necessarily targeted at lower wage employees. They're really targeted at almost like wealth management. And what I think was being mentioned previously is this idea of kind of starting small and starting with these sort of initial steps of developing, what's the ladder? What are the first couple of steps that somebody needs to take to get to financial health? I was thinking as we were talking earlier, there's been a movement underway for a long time around mental health parity in the context of medical benefits. And it feels like there's an opportunity for financial health parity to be something that's considered. And I don't think the focus has been on lower wage employees or frontline employees or hourly employees. It's really been on almost in the context of the more white collar employees. So what we do is very much do single sign-on, deep integration of different services and programs, including financial health programs. And one of the challenges that we've seen, and I guess I throw this down as a gauntlet, one of the challenges that we've seen is that some of the slowest, lowest tech responses from some of these large players has been in the financial services world. That it's been harder for them to seamlessly integrate, to seamlessly share data, probably because of privacy. I'm sure there's lots of different reasons, but that ability to get somebody in and started very quickly feels like a real opportunity that's currently being missed.
And
one of the things that
from the voice of experience, that there are solutions out there that are not difficult, they're pretty painless. But one of the things that we had to step back and look at was the stigma that's attached to financial unwellness, to financial sickness that your employees have. It's kind of right there with mental health. Everybody they're dealing with it in some way, shape, or form, but they don't want to talk about it. So when you're looking for solutions, it's really important to look for solutions that remove the employer from the equation as much as possible. And when we did that, we had great success because it was the employee communicating directly with the vendor through a portal. And as the employer, we didn't know what the problem was. We didn't know how much they asked for. We knew nothing except how much type of assistance they were getting through a payroll deduction. And taking the employer out of that, I know, made a significant difference in the success of the program.
Yeah, and I also think too, not only the programs that you offer, they should be targeted to fit the population and what their needs are, but the how you deploy. So the point about taking the employer out of something, I think is super, super important, but also how do you communicate to the folks so they actually pay attention and have the time? I know for our retail employees, it's really hard for them during the day because they're on the floor to look at emails and look at the traditional ways of communicating. So what we found is that actually, having sessions and a multiple amounts of those sessions throughout the day to fit the shifts so that folks can actually be pulled off the floor and make sure that they get compensated for that. So they have the time to hear and take it as an important way to listen to what's available. And we really saw some great results as a focus area of that, and also the same for the call center. So I think the how you deploy is really important.
Thank you. All insightful comments. I'm cognizant of our time. I want to jump to a little bit around discussion that's happening among employer networks about the evolving social contract, not only because of the current health crisis, but with the additional economic downturn and racial tensions that I was alluding to at the start of our panel. And I'm curious, how do you see this shaping employee expectations about what employers need to provide employees relative to financial and physical and mental support? Robin, maybe I'll start with you on that.
Yeah, in businesses like ours, where our primary asset is our people, we've always been focused on supporting our employees so that they can do their best work in service to our mission. COVID-19 has really deepened the need of our employees in so many ways. And we've had to really think about supporting them in ways that we didn't, prior to COVID-19, as I spoke about earlier, in terms of their physical safety and their mental well-being and financial health. Our experience over the last 3 months has really demonstrated that staying tightly connected with them and through these multiple channels that I'm talking about, and it's not just surveys, right? It's through having different forums where you can listen, smaller group sessions for people, having them being able to anonymously send a note or not anonymously. And if you keep those lines of communication open, it'll allow you to make the necessary changes, situations involved, and you get an opportunity to hear what's on their minds about all the problems that we're seeing in the world, and you can really respond to those in a way. I think that you can put them together versus trying to handle them in very specific different ways. It's kind of, like I said earlier, like the holistic approach to your employee through their life cycle while they're there. You have to be able to respond to many things, but some of the solutions can be the same. And it's just giving them a forum for them to be able to talk and share what's on their mind.
Yeah, there's a lot of interdependencies there at play. Mm-hmm. Sherry, what about from your point of view?
Yeah, what I see is that organizations are taking advantage of reviewing policies, including benefit plans, to have more diversity and inclusion in the programs. There's continued focus and transparency, certainly equal pay for equal work, but also for opportunities for further growth and development so people can thrive in their careers, to help them with financial health, and then also providing safe work environments for all.
That's great. And Cheryl, anything you want to add from your point of view?
Well, I will say, Robin and Sherry stated it brilliantly. I'll only add that the way businesses and their leadership work with their employees during these challenging times is going to determine how their employees work with them in the future. Employees expect us to see them as individuals, to meet them where they live. They want us to invite them to bring their authentic self to our workplace, and they'd really like it if we meant those words. So as employers, business leaders, human beings, you have to decide how important that social contract is between you and your employees. And if it's genuinely important, then it's time to stop judging and to start helping.
Thank you. So we just have a couple minutes left, and I'd like to kind of bring this to closure and just ask each of you if there's one key takeaway from this discussion, or is that you've been thinking about health and wealth in the workplace in general that you want to be sure to leave our audience with. What would that one kind of takeaway or final thought be? Mary, I'll start with you.
So as we were talking, a few words came to mind for me, and I think there are things that some employers have focused on and a lot of employers have not necessarily focused on. I love this idea of financial health parity along with mental health parity and physical health parity. And then the words that come to mind for me in the context of additional opportunities include thinking about programming and benefit design around developing equity, developing empathy, and developing resilience. And those things can mean lots of different things to different people, but it feels like there are opportunities to think about those as themes in the context of benefits we bring forward.
Yeah, it seems like in these times, care and empathy and compassion are coming to the forefront from an employer perspective. Sherry, what about you?
Yeah, my takeaway is certainly that employers do have a responsibility as we intertwine financial and physical health. And so we have an opportunity to focus on awareness, education, and empowerment for our different employees and also the consumers. And so again, that's why I'm super excited about HSA Day, because that's my personal challenge to internalize the campaign and help people on October 15th with just more education and awareness, and help people again as they strive to kind of balance both their financial and physical health needs.
Great. Cheryl?
Well, my hope is that the folks attending today fully comprehend that the physical and emotional security that comes with financial stability is priceless. The workforce has this need, and as business owners and employers, listen, it's strategically advantageous, it's straightforward, it's pretty painless, but most importantly, it's the right thing to do to provide these programs to our employees.
Thank you. Robin, you have the last word.
Yes. So if I haven't been clear throughout my comments, is listen to your employees and act in ways that best fit your company, and do it on a regular basis. I think we've learned a ton through this crisis, and I hope that in our world, much of that learning sticks so that we can continue to be strong employers and provide great experiences for our employees and help their lives.
That's terrific. I just want to thank all the panelists for a great discussion, and I want to thank our audience as well. Thank you, and have a great rest of your day.
So it's well known that more wealth is correlated to better health. The wealthier you are, the longer your life expectancy, the better your health is. It's a term of art called the social determinants of health. But the converse is true as well. Better health can lead to improved wealth. So of course this applies to the 9% or so of Americans who are uninsured. They of course bear the full cost of any healthcare costs. But fully 43% of Americans are now covered by a high deductible plan, which means that their insurance doesn't kick in until they hit a certain level. For 2020, that level is at about $1,400 for an individual and $2,800 for a family. I think as you may know, 70% of Americans have less than $1,000 in any sort of liquid savings account. So it isn't surprising then, given these two facts, that the vast majority of bankruptcies in this country have something to do with healthcare costs. Indeed, about 2/3 of people who file bankruptcy cite healthcare costs as a major contributor. Poor health obviously can mean that you're out of work and end up on disability. And even when you retire, Fidelity estimates that the average male-female couple retiring in 2019 should expect to spend over $285,000 of healthcare costs over and above what Medicare will pay. And that doesn't even include any costs for long-term care such as nursing homes. So if we are going to want to help Americans build and preserve any sort of wealth, we have to focus on their health, improving how healthy they are, and if they get sick, optimizing the amount of money they have to spend. So unfortunately, the current US healthcare system does a lousy job at these. The system is largely built around fee-for-service payments, where doctors and hospitals get paid for each thing they do. Therefore, what they do is they do more of everything they do. So to help address this, what we've responded to is by saying we're going to give patients, quote, more skin in the game by creating these high deductible plans and put as much of the economic burden on them. This would be fine if we thought that they could actually help make these decisions. The problem is medical care doesn't really work this way. There are huge asymmetries of information. The doctor knows much more than you do. There are huge power asymmetries. Imagine you lying in a hospital bed trying to comparison shop while a doctor is standing over you with a white coat and a big needle in their hand. And pricing is completely opaque. There's no way that you know what any sort of comparison pricing is. What's happened is we have moved in healthcare similarly to what we did in retirement, from pensions to 401k programs. So my father worked for a hospital system his whole life. He worked there for 20 years, and the deal was you work for us for 20 years, we will take care of you in retirement, a defined benefit. What happens now, my employer, is we get a defined contribution. We're going to contribute this much to your 401k plan, but it's up to you to decide how to invest the money, and good luck to you whether you have enough money left at the end to retire. So what's emerged in financial services is a whole network of financial advisors to help consumers make these choices and end up at the right place. So what I would argue is that's what we need in healthcare, a set of financial advisors, or what I call healthcare advisors, to help you make those decisions. And our proposition is that primary care is the best place to do this. So the problem, though, is current primary care is not at all equipped to help people with it. Most primary care is paid fee for service. You have 7 to 10 minutes with people. You are not able to really have the time or the information to help them. You're reactive, it's fragmented, and too often primary care doctors these days don't work for you. They work for the hospital system, where they're actually encouraged to order more tests and procedures often, or they work for the health plan, where they might be encouraged to not order more tests or procedures. The very simple answer is what you need as a consumer is a primary care doctor who works for you, with the period at the end of that sentence. And then what you need is that primary care doctor to work very differently, to really focus on your health and helping you navigate the system, not just writing more prescriptions. So about 9 years ago, I started a company called Iora Health, and the whole goal was to start a primary care system that actually did this, serve as financial advisors or healthcare advisors for patients through the system. So several differences. So the first thing is how we're paid. We don't get paid fee for service per thing we do. We think that puts us in conflict with our patients. We don't get paid more for doing more. What we do is we get paid a fixed amount, and we get paid to help you navigate the system better and lower your healthcare costs. Now, all of a sudden, our incentives are aligned, and we don't work for a hospital or a health plan, we work for you. Second is we then completely change how we organize the practice. So of course we have doctors. I'm a doctor. Our job is to help prescribe and tell you what you should be doing. But the hard part isn't doing that. The hard part is actually for a patient, how do I execute on this plan? So we have people we call health coaches who can work with you one-on-one to help you actually execute on the plan. Take your medicines, know what to eat, know what to track, hold your hand when that's the right thing to do, kick you in the behind when that's the right thing to do. We also have behavioral health specialists in the practice to help with depression and anxiety. We have social workers who would help with any sort of programs you might need to be hooked up with. We can communicate not just by having you come into the practice, but by email and text and video chat. We get patients together to learn from each other. We'll reach out and see you at the home if you need to. If you need a ride, we'll send an Uber to pick you up. Your daughter can Skype in for the visit. You can see your whole medical record online. This is not a little different. It's completely different. We build a de facto narrow network, a set of specialists and hospitalists who we collaborate closely with, again, to help you get the right healthcare at the right cost, not actually trying to gin up bills for someone else. We also have put a different sort of IT platform to really help us do this. The typical IT platforms for primary care are built to help people document, code, and bill hire. We don't care. We have one that helps patients engage in their care, understand what they're doing, what they're spending, and optimize that. So how does this look? Let me tell two stories to really illustrate both the failings of the current system to help preserve patients' wealth, as well as what we can do to help. So the first one was a patient that we saw who came to us in Boston. And again, step one is really to make sure people are getting the right things done that they actually need, and not get the things done that they don't need. So this practice in Boston was one of our first retail practices. People paid $40 or $50 a month to come see us. And we had a gentleman come to us and said, "Can I buy a membership for my mother? She lives in New Jersey." I'm like, "Why would you want that?" And he said, "Well, because she is old and I don't trust her doctors down there. She always asks me for advice. Will you do it?" I said, "Sure, I need to meet her. She needs to agree." So she comes in to see me. And she was a charming little old lady in her late 70s, little arthritis, little hypertension, and a few meds. I wished her the best of luck, and she gave her my number, and she went on about her business. About 3 months later, this gentleman called me up, and he said, "Rushika, my mom called me. She's about to get a pacemaker." I'm like, "A pacemaker? She seemed fine to me. What's happening? I don't know. Can you check?" I said, "Absolutely." So I pick up the phone and I call the lady. So what had happened is a week earlier, she had urinated, looked in the toilet bowl, and noticed some red in the toilet bowl. So like a good doobie, she said, "I'm going to go to my primary care doctor." Does the primary care doctor saw red in the toilet bowl? And the primary care doctor said, "You should go see a urologist." So goes to the urologist. The urologist said, "Ma'am, he's a hammer. The word looks like a nail. Ma'am, this could be cancer. I need to do a cystoscopy, put a camera up your bladder to see if it's cancer." Now, the most likely thing this is, red in the toilet bowl for a little old lady, is what's called beet urea. She ate beets. Completely harmless. Second most common thing is this is a urinary tract infection. She probably had a little bit of a UTI, and you could check that very easily with a dipstick. Third is she has hemorrhoids. You can check that very easily too, but this primary care doctor did none of those, just sent her straight to the urologist. So, urologist wants to get by the way, I asked her what happened to the red in the urine. She said, "Oh, it went away the next day." This is all a wild goose chase. So urologist wants to do a cystoscopy, but "Ma'am, you're old. You need to go to a cardiologist to get your heart checked out before I do this cystoscopy." Goes to the cardiologist's office. Cardiologist nurse with a review of systems. "Ma'am, do you ever feel weak or dizzy?" "Oh, sometimes, Sonny, I feel a little weak and dizzy." He says, "You should do a Holter monitor. It's a patch that you wear to monitor your heart rate." So she takes it home, wears this patch for a day or two, comes back. He looks at it, and she has what's called asymptomatic bradycardia at night. Her heart rate goes slow when she sleeps. Completely no symptoms. He said, "Ma'am, that could be dangerous. You need a pacemaker." So that's where she ended up where she is. So I said, "Wait a second. First of all, it's not clear why we're doing any of this workup, because this went away and this is a wild goose chase." Number two, they called a friend who's a cardiologist at a big teaching hospital. Is this a asymptomatic bradycardia at night an indication for a pacer? Absolutely not. The risk of sticking a trocar in her groin, putting metal in her chest, way outweighs any potential benefit. Third, I said, let me look at her medication list for her hypertension or high blood pressure. she's on a medication that actually slows her heart rate down, called a beta blocker. We could switch that, put her on something else. So I called the cardiologist, said, I work with the family. We politely decline your pacer, and next time you should check the med list before you prescribe a procedure. So this gentleman was very thankful. He said, well, you just saved us, a huge procedure, a lot of money, and not to mention my mom's health. He said, tell me, does that cardiologist make money off the pacer? Absolutely. Does that urologist make money out of the cystoscopy? Absolutely. He said, what I love about you is you don't have a dog in this race. You work for me and you work for my mom, right? That's what we need. Second is, I think, apart from whether you get the right procedure, is pricing. Pricing is egregiously different, particularly in the commercial space while you're working. We had a practice up in New England, and we were working with a big health system. And what we would do is we would draw blood in our office and send it to their lab. So a patient came in one day, and she had one of these high deductible plans. She said, Doc, you're going to order a Chem 20, a really simple test. How much will that cost me? I said, that's a really good question. Let me figure that out. So I called the lab at this academic health center. I said, we're about to order a test for this lady. How much will it be? And he said, doctor, it's really complicated. I said, don't patronize me. You will send this lady a bill. That bill will have a number. You expect her to pay that number. I want to know what it is. You go to a restaurant, you order a steak, you want to know what the price is before you eat it. He said, I won't tell you, why don't you call the health plan? I called the health plan, Anthem, and they said, our prices are secret. I was like, how can the price be secret when the patient is expected to pay the amount? Get every excuse in the book. I said, you idiots, I have all your claims data. We get all the claims data for their prior claims. I want to figure this out. So it turns out this test costs about $20 or $30. The price that this health system was charging for it was $150 and hiding it. And by the way, incidentally, if you're a poor uninsured fool who walks up, that price would be $320. So this is a 10-to-1 difference in pricing, which is kept opaque, right, and hidden. So really, we think that for patients, if they want to try and improve their wealth, whether they're working or retired, that actually paying attention to healthcare and your healthcare costs, what you get, whether you need it, and if you do need it, getting in a place where the price is reasonable is really important. And that it's really hard for patients to make these decisions by themselves. We believe primary care practices like us, equipped with the right sort of tools, the right incentives, the right payment models, are a hugely important way to help patients actually make these decisions and improve their health and their wealth. Health and wealth are inextricably linked. We believe new primary care models like ours are key to helping consumers optimize both. Thank you very much.
Good afternoon, everyone, and welcome to our next panel exploring the intersection of technology-enabled solutions in health and overall health and financial health. My name is Matt Ball, and I'm the Vice President and Market Lead for Workplace Financial Health here at the Financial Health Network. And I'll be moderating this panel of our esteemed guests who are going to dive deeper into a lot of the conversations we've heard today, principally exploring ways that technology and tech-enabled solutions and innovation can further connect, impact, and solve for the financial health challenges as they overlap and intersect with overall health and well-being. As we get started, I'd like to ask each of the panelists to provide a brief introduction, to highlighting their professional background, and in a sentence or two, highlighting why they're passionate about tech-enabled solutions and why they believe it's important to connect health and financial health together. I'd like to start with Tom Spann.
Thanks, Matt. I'm Tom Spann. I'm the Chief Executive Officer of Brightside. We're the first financial care platform for employers, and we think about financial care, and this sort of gets to why I'm passionate about this, is different from financial wellness, like healthcare is from physical and mental wellness. It's good to have financial wellness, but when you look at a country where only 29% is financially healthy, then you've got a lot of financially sick families, and they need more than just coaching. They need real solutions. So with employers paying us, we're able to not only help their employees navigate the complex world of financial services, but we can offer unique paycheck-linked products that employees can't get on their own. And while we're not a bank, we can be the financial home, much like the medical home concept in healthcare. And since we're not making money from fees and interest, we can do things banks don't do, like lower your interest rate when your credit score goes up. And I sort of got passionate about helping working families when I was the founding CEO of Accolade. So I did that role for 9 years before hiring a new CEO. And that was a company that helped employees and their families navigate a different complex system, the healthcare system. So it's probably why I'm bringing some of that healthcare language into financial health. And and Brightside was the idea of one of Accolade's customers who said, something like Accolade is needed in the financial health world.
Great. Thank you, Tom. Harsha?
Yeah, thanks, Matt. My name is Harsha Kubala. I'm the co-founder and COO at MedPut. And for me, I actually grew up in India. My parents are doctors. They ran a hospital. Probably a little disappointed that I'm not a doctor, but it's a much longer conversation. But I've always been around healthcare. And in developing countries, you see quite often that wealth and health are clearly correlated. And when I moved to the US, I realized it's the same here as well. People who are well off get better treatment. And I really feel like technology is a great equalizer. And I'm excited to use the opportunity to use technology to actually scale solutions that reach people that have been historically underserved through financial products. And that's really the reason we started MedPut. MedPut is an employee benefit that provides interest-free financing and bill discounts for any out-of-pocket health expenses for employees. So we sell to employers. Employers offer MedPut as an employee benefit. And whenever there's a bill, the employee just needs to take a photo of that bill, submit it to us, and they're done. So we negotiate that bill, we pay the hospital or the doctor directly, and then we get repaid through small interest-free payroll deductions. So it's basically a way to prevent people from putting bills on a credit card or from taking a payday loan or a 401k loan when they can't afford to pay for their healthcare bills.
Thanks, Harsha. April?
Hi, thank you. My name is April Gill. I'm the Senior Vice President of Solution Management at WellTalk. I will just start with my passion first. I've spent over 20 years in healthcare, really focused on organizations that are, technology enabled, primarily high growth. I've worked with all stakeholders, health plans, providers, employers, and everyone is trying to solve similar problems, but from a different perspective. And so my passion is really about bringing technology to bear to improve overall health and well-being. And that's really what WellTalk is all about as well. So, we are pioneers in the world of consumer activation. And for us, that really means getting people to do the things that help them manage and improve their health over time, which encompasses financial health and well-being, in addition to many other aspects of what you traditionally think of in healthcare as ways to be healthy or manage your health.
Great. And Tom Castles.
Sure. Hey, everyone. Tom Castles. I'm the president of Rock Health. Really excited to join the conversation today. Rock Health, for those who don't know, is an interesting two-sided business. We are, since 2012, we were the first seed stage and early stage VC fund to focus solely on digital health solutions. We've continued that focus. We now have a second side of the business where we advise and work with quote unquote the buy side of healthcare, which are the large biopharma, health tech, hospital and health systems, health plans, to really reach a goal of accelerating the adoption of technology-enabled services and digital therapeutics. My passion for this conversation is a woman named Monique. Monique is my mother's social worker, and in reality, my social worker, as my mom has early onset dementia. We are working with 3 children across 3 states to really address the challenge that is not just the actual disease, but the complexity of dealing with the financial aspects, the health aspects, the social aspects. And so I don't think you can talk about healthcare without talking about finances these days. That makes me passionate about being here with you today. Looking forward to it.
Well, thank you for sharing that, Tom. And I want to turn over to Tom Span first. Tom, there's been lots of discussion and some research relative to the impact that financial stress can have on overall health. I'm wondering if you wouldn't mind sharing your perspective on how you're seeing financial stress impact overall health, and how do you think tech-enabled solutions can better target financial stress and then measure the impact it would have on health outcomes?
Yeah. So, a lot of this has been discussed in some of the other sessions today. Financial stress is a big part of it, right? It's obviously a result of poor financial health, and the evidence that stress makes you sick is overwhelming. And and the financial stress may not even be something somebody self-reports as the primary stress. 48% of all relationships have fights over money every year, and that's the biggest predictor of divorce, according to the Family Relationship Journal. 65% of Americans lose sleep over their finances every year. That's in good years. Like, this data is all pre-COVID data. 75 to 90% of all doctor visits are stress related. And 7 of the top 10 medicines in the United States are for stress related disorders, depression, anxiety, ulcers. There's a lot of focus on that part as people talked about the economic impact of COVID. The increase in anxiety, depression, suicides, but I think that's only a piece of the story. It's supposed to start to come out earlier. What I saw at Accolade was by far finances were the biggest barrier to getting good care when you needed it. And what I think Accolade proved out, and a lot of other businesses in that space are now proving, is, the healthcare industry grew up trying to make it hard for you to make mistakes in healthcare, but it made it hard to do anything in healthcare, usually with financial things, things like high deductible health plans. But the reality is getting that right care sooner is better. And there's been a lot of great work by Saul Wiener, University of Chicago. He studied both doctors and hospitals and Accolade, and 65 to 75% of everybody who presents has some sort of life context barrier. A lot of people call it social determinants of health, but even busy executives could have time constraints. There's other things that aren't biomedical, but 70% of the time that barrier is financial in this country for working Americans. And the cost of not addressing it is 10 times that of making a biomedical error. Right? A doctor who makes a medical mistake, that costs on average $30 a visit across all the visits in the United States. Missing the person who can't afford their meds and prescribing a more expensive med when they weren't taking the one they had costs $231 for every visit in this country. It's a huge driver of waste. 44% of Americans skipped a doctor appointment in 2017. 40% skipped a recommended procedure. And so you can start to see why, you add the community factors into that, right? People live and they don't have the support in their community to be healthy. That was talked about in the great opening session. 4.5% of all deaths in this country every year are from financial health, right? They're from poverty and people not having the money. there's a great book by Richard Cooper on poverty and the myths of healthcare reform, where he sort of says a lot of the work of the early part of the century was misdirected in terms of tackling the system. If you actually could tackle the economic disparities, that would take 30% of the costs out of this healthcare system. So you can see the tie between obviously income and financial health, but it's also income and physical health, but it's also income and financial health. So, what we've done at Brightside is use technology to build rules engines for a financial system. So we build a business where we think, given this complexity, all those contextual barriers, social determinants of health are also social determinants of financial health, right? There's a lot of things that get in the way when your mom steals your car, so you lose your Uber Eats second job, was paying for your kid's daycare. Now you're staying up all night because you can't afford daycare, and obviously not a particularly productive worker when you go to work in the day. Or somebody, a family member put their utility bills in your name, didn't pay them, now your credit score is going. That kind of, those kinds of things you've got to address. You can't just hand somebody an app and say, here, this should fix your finances. So we've used technology to be behind those financial assistants, those people, so everybody gets their own coach, their own financial assistant. We use technology to help collaboration in our mobile app between the financial assistant and the employee or their family member. And we use the technology to monitor ongoing financial health. So that's kind of how we're thinking about it.
Yeah, that's great, Tom. It's like almost how do you help provide the support and apparatus that help people manage just the day-to-day living activities, given their unique context and circumstances, and then using technology to understand people's lives and then deliver solutions that meet them where they are in ways that extend even beyond the workplace, but into their communities.
Exactly.
I want to turn to you next. And, thinking about the work that MedPut does, but also just your personal background. I'm sure your parents are proud of you despite not being in a physician, and there's still time. You could do both. There are plenty of folks who are innovators and physicians. But I'm wondering if you could maybe talk about what are some of the financial pain points that you think are most commonly experienced as people encounter our medical system? And what are ways that technology can help solve for that? And I'm thinking particularly on the comment from an earlier panel about people delaying getting treatment because of high costs. How do you think about that? And how are some of the additional pain points manifesting?
Yeah, absolutely. I think there's a few key pain points, right? The first, and this is something that's been in the news a lot, is transparency and pricing. Healthcare is basically the only industry where a consumer purchases a service and they have no idea what that service is going to cost, right? So you're consuming something, but you have no idea what it's going to cost. And on top of that, you don't know if the charges are accurate. So even if you had an idea or an estimate of the cost, you have no basis for knowing whether the price is accurate or not. And there's a pretty decent chance that there are mistakes, right? And then there are exciting technology solutions that are kind of addressing both of these issues, So there's a lot of startups that are working on identifying high quality, low cost providers. I know Walmart also has some centers where they disclose prices transparently upfront, and people know there's a fixed price. So there's a lot of work being done there. There's also tech companies that use AI to go through your bills and be able to identify if there's a likelihood that there may be some mispricing involved in there. So those are two of the big issues. And even if we were to solve for both of these challenges, the fact remains that healthcare is still way too expensive, So even if we were to help bring transparency and reduce the errors, if you look at the way healthcare costs have inflated relative to savings rate and wage growth, it's a no contest, right? So over the last decade, deductibles have inflated at probably 5 or 6 times average savings and wage growth. So that delta is going to exist. And I think there have to be solutions that are impacting people's ability to pay. So a lot of revenue cycle management solutions affect individuals' willingness to pay. But in addition to that, there have to be low-cost financial or payment plan type solutions that actually allow people to make payment. And I think this problem is actually going to be exacerbated in the future as more and more services are being shifted to ambulatory care centers instead of hospitals, because the co-insurance charges at these facilities is bone crushing, no pun intended. And so a couple of years ago, I had an ACL surgery from a soccer accident, and it was like a 25-minute procedure, and the bill before being discounted by insurance was $115,000 for a 25-minute procedure. So even if that is discounted, just imagining co-insurance on top of that would make it extremely difficult for the average American to pay for it. And I just wanted to add one other thing, and that's to realize that in addition to individuals feeling the pain, there are multiple stakeholders, all of whom are impacted by the situation. So just take the example of a person who goes into the hospital, comes back with a $2,000 bill. He uses his credit card to make a part payment and is not able to make future payments, right? And is then sent to collections. So if we just take a step back and look at all the stakeholders that are affected, first is the individual himself or herself. That person's paid credit card interest. Their credit score is going to be affected if they don't pay in time, and they're under a tremendous amount of financial stress, like Tom just mentioned. Now, if you look at the employer, because that employee is under financial stress, that employee is not as productive at work. They're going to hesitate to go in and get treatment the next time they have an out-of-pocket expense. So that's going to increase the percentage of emergency visits, reduce the percentage of primary care visits, which will shift the cost curve upward. And that person's a higher termination risk because they're looking for other places where they can have better health coverage. The provider is affected because now they've performed a service for which they've not been compensated, and that relationship with the patient is damaged. And even in the insurance company is affected because now people are going to delay treatment. It's going to make the population health on average worse off. And when it comes to negotiating payments with hospitals are going to say, hey, you guys have been pushing out these high deductible plans. We haven't been able to get paid, so we're going to have you charge you higher, and so it turns into a vicious cycle. So this is an issue that affects every stakeholder in the system.
Yeah, and I think the point about you receiving a $115,000 bill also speaks to some of the changing ways that care is being transformed, right? As we see more push towards outpatient versus inpatient and the shifting cost structures, which no matter how transparent the system is, those cost structures are driven so much by the payment side of the house. And so I think those are also important things to think about, is the complexity of the system and how technology can potentially solve for some of the cost barriers, but there's still the care barriers and other barriers that are impacted through that. Very interesting. And because of the level of your jokes, you could also be a stand-up comedian. So your career is bright, Harsha. You have infinite possibilities. April, I want to turn to you. And we heard from the employer perspective panel earlier about the role that employers are playing. And one of the challenges I think employers face is this field of dreams fallacy, which is just because they build a financial health program or they have a healthcare program does not mean employees will come and use it. And so given the work that WellTalk does in your own background, how should we be thinking about engagement? And how should employers be thinking about ways to leverage technology to better engage their workforce in the right solutions at the right time?
Yeah, it's a great question. I think, I won't be as bold as to say you shouldn't think about engagement, but what I will tell you is everyone defines engagement differently. And at WellTalk, we really think about activation, which means people doing things that move the needle towards improving their health, whether it's financial health or truly managing a condition, or just remaining healthy so that they don't have rising risk. And that activation is really driven by understanding who the population is. So taking lots and lots of data and information, we talked a little bit about social determinants of health. That's definitely a factor. To really get a 360-degree view of a population is sort of the backbone of how you start to then affect both engagement and activation, because you need to understand who needs what or who has specific risks. And then also, what are their behaviors? Are they actually ready to change? Are they ready to engage in a particular program? Will they finish it? And will they have a desired result? And those are all of the things that our analytics identify. A tech-enabled, program to help people manage their health, regardless of what the category happens to be. To your point, that if you build it, that doesn't mean that they'll come. So having a program that has a coach associated with it, or a program that's self-directed, those are really key components of serving the totality of what a population may need. And being able to identify who's going to be most receptive to and likely to be impacted by that program with a coach behind it, because they need more hand-holding, versus those that will do a self-directed program and have a desired effect, allows you to use resources more efficiently, so that you can really align the more high-touch approach for those that need it, and a more high-tech approach for those that are tech-savvy and can go through that on their own. So I think, understanding engagement is important. Obviously, if people don't engage, then they're not going to do anything. But it's really understanding who got their flu shot, who went to see their physician, who went through a training program around financial health and actually opened the right account for them based on their stage of life and what their financial goals are. Those are the kinds of things that I think are the most important to measure.
Yeah, that's really impactful.
But I'd also add that the employers have a lot of say in their employees' journey, right? One of the things that worked at Accolade was just, for example, being the number on the back of the insurance card, which created, huge engagement opportunities, because people were about to use the healthcare system almost every time they called that, and usually with some sort of financial issue, right? Is this covered? Is that kind of thing? And on Brightside, we're seeing the same thing, right? When you start a new job, that's a moment that matters. When you go on disability, you lose a third of your income. That's a moment. You ought to be getting financial care in those moments. Employers can certainly at least make it a strong default in these journeys before people do things like take out a hardship withdrawal on 401k.
Yeah, that's a
great. I totally. Oh, sorry. Go ahead.
I was just going to compliment Tom, so please, you go.
I was just going to say, I wholeheartedly agree with that. And I think it's really crucial for employers to remember how humans work, right? The human brain only has so much capacity to manage stress and crisis. And in the current environment, we pretty much have hit our maximum. There are benefits that all employers offer, that many health plans offer as sort of a throw-in value add, like EAP, that provide financial counseling, access to a mental health counselor, legal advice, all of those kinds of things. The average utilization rate for an EAP program in the United States is 1% to 2%. Why? Because you only ever need it once in a great while. And when you're in a crisis, your brain actually can't think the same way that it does when you're not. So you can't even remember what you have access to when you're trying to manage through that particular issue. You need to have the ability to drive that into the face of the person who needs it when it's relevant for them. That's the best way to really get them to be aware and utilize the things that you've invested in as an employer.
That's really great, April. And I think you should be bold and say engagement is not the goal, but activation is. So I think that's a really important distinction that would help a lot of organizations think differently about how they deploy solutions to their constituencies. I want to go to Tom Castles. And Tom, you raised a really important reality for so many folks in your opening statements around caregiving and the really interesting intersections of health and financial health as it relates to caregiving. I'm wondering if you could maybe expand a little bit on how you're seeing financial and overall health impacts on the caregiving environment, and what new innovations are you seeing that are seeking to address and remediate some of those challenges?
Sure. It's every day as a VC, I talk about total addressable markets. One of the things that a lot of people don't know is that caregivers in the United States are one of the largest total addressable markets out there. So right now, 1 in 5 Americans is a caregiver giving unpaid care to a loved one, a neighbor, what have you. This is almost evenly distributed across generations. So this is not a Gen X taking care of an aging boomer population. I think actually 37% of these caregivers are either millennials or Gen Z. A large part of that is because they're a caregiver to not just grandparents, and people think of this as a kind of the gray wave. Actually, it's both the aging of our country and the incidence rate of developmental disorders for children in our country. I think it is shocking that 60% of all of these caregivers are working. These are your employees. These are my employees. And 61% are women. So, we're going to talk about equity a little later, and I have a lot to say about that. The health impacts for caregiving are pretty stark. And I think Tom mentioned it earlier, and I think perhaps everybody hit on this, but 20% of all of the caregivers in America report a health decline from year to year when they are actively caregiving. And that presents in terms of high blood pressure, that presents in terms of depressive disorder, substance use disorders, mood disorders, all of which, by the way, we have a massive supply-demand gap for. The financial impacts are really shocking. 45% of all caregivers have had at least one material financial impact in a given year. And that ranges from paying a very expensive bill to asset management decisions that you have very little knowledge of how to make with respect to, especially for long-term care, access to Medicaid services. The one that personally gets my goat the most is that, we like to talk about, we want people to be able to age in place. Aging in place is a luxury good in this country. And it's a luxury that almost no one can afford. And it's all out of pocket. So that kind of reality, I'm actually optimistic because of the companies that I'm seeing who are running at this space, and running at the space as what I would call, and Tom would know probably more than I, kind of navigation technology enabled services. And they come in two flavors. One is actually caring for caregivers. So a couple of companies that are doing some really excellent work here, Care Tribe and T-Care, really kind of putting together services for the caregivers themselves to keep them healthy so that they can keep their loved ones healthy. The other flavor is care coordination. So especially for frail elderly or pediatric developmentally disabled or physically disabled children, you don't have a doctor. You have 5 doctors and 4 therapists, and they don't talk to each other. So, the organizations that I see, like Unite Us, MadPow, Atlas of Caregiving, these are folks who are really looking to tie those pieces together so that you can have actually a power derived from that large, currently fragmented team by really bringing the team together around your goals. So as rough as those numbers are, I am optimistic that we're seeing people invest behind them.
That's great, Tom. And go ahead, April.
I was just going to say, if I could just add to that, that the issue of aging in place, it really is hitting everyone, right? So there, in a recent survey that AARP conducted, 57% of Americans want to age in place, but there are only 10% of them that can afford to do so. And when you're like me, I am actually in a sandwich. I have kids in college, kids at home, and I have an elderly parent that I care for who lives with us. She was in an untenable situation, living in poverty, living in a place that was not safe. We had to literally pluck her out of a different state and move her, which meant a whole host of issues that we hadn't anticipated. When you think about parents in retirement, or when you think about caring for a loved one, typically you plan, and we did. But what I didn't know was what it was going to take to find the team of doctors, what it was going to take to make sure medications got transferred, there's this whole list of things, not to mention the isolation associated with getting plucked out of a place that you've lived your whole life and moved to another state with no support system except for us. So I just wanted to, A, share a personal anecdote, but B, really underscore the importance of understanding the situation that employees are in and the kind of burden that they've taken on out of sheer necessity. And it's not about enough planning, right? These things are unexpected. It can absolutely take a toll on overall health when those kinds of things pop up, because they feel insurmountable at the time.
Yeah, so very true. And I think, some of the numbers that Tom Castles provided around just the number of individuals who are even unbeknownst to themselves in caregiving roles, I think is really staggering, and certainly speaks to the need for innovation and thinking creatively about solving those systems. We did get a number of questions from the audience, so I want to try to address some of these before we wind down the session with the equity question that I think is important for us to get to. So I want to raise this question, maybe direct it first at Harsha, and then others can chime in. Harsha, we had a question around tech companies' ability to, in light of HIPAA, to unify someone's health data in one place to allow them to make better decisions around which provider they would go to, as opposed to being locked into a single provider. So speaks somewhat to the transparency issue. So maybe have you, Harsha, speak, and then April or others who have any thoughts can add to it.
Yeah, absolutely. So I think there's a company called Healthcare Blue Book. There's a few others that allow you to see, based on a given service, what the top quartile or the top percentile providers charge, what the lowest quartile or percentile charge, what the average cost should be. And then also on top of that, there is the quality weighting of these prices. So I think there's a lot of startups that are looking to actually compare pricing by location and then layering the quality on top of that so that people can make an informed decision. And your health plan and your network information is often fed into that. So it's pretty clear what your out-of-pocket cost is going to be. And there's also a lot of insurance brokers, especially for self-insured companies, who have a list of preferred providers where there's often no out-of-pocket cost. And that's a way to reduce costs, not only for the employees, but for the employers as well.
Great. We had a related question, but I want to get to another one before we circle back. And I'm going to direct this one to Tom Castles to start with, but how do you think about, from a VC perspective, sort of the need to address the symptoms of the broken healthcare system versus the root causes of the healthcare system? And so how do you think about where innovation plays a role? Is it playing a role in solving root causes, or is it playing more of a role in sort of plugging the outpour from the symptoms?
it's hard not to be blunt about this question.
That's why I asked you, Tom. I figured I'd get a blunt answer.
Innovation that's necessary is investing behind people of color and women. It's kind of hard to help caregivers who are disproportionately in those categories unless the folks who really know the problems that they're facing are the folks that are building technologies and new business models to actually make healthcare not just available. You can make an argument that every ED is available. It's not accessible if you're going to be treated like a second-class citizen because of your race. It's not really accessible if you can't afford $50. So my optimism is that more people, my fund included, are going to invest behind the folks who are best suited to actually understand the jobs to do that these folks have, and build services that, frankly, I think a lot of the people that I've invested in, they work with the Medicaid community, but it wasn't by design, and that's the innovation we need.
Great. We've got about 3 minutes left, and I want to make sure we get to a really important topic and question, and that's around this equity piece. And I want to start with you, Tom Spann. I'd ask you to use the time to answer this question, then also provide any closing thoughts you may have. But as we continue to see the impact of COVID, as well as all of the recent events happening across the country, focusing on systemic racism, the impact and disproportionate impact of outcomes on people and community of colors, what role do you think that both employers and tech companies and innovators play in helping to address and remediate some of those challenges? It's a big question, but you only have like 30 seconds apiece.
I probably build on Tom's answer to the last question as well. If in fact there's, 30% of healthcare costs are driven by this accessibility problem, of which finances is the biggest barrier, right? These issues, you can separately work on addressing racism in the provider community, but I think people serving these communities, the doctors and nurses, are trying to do the best job they can. That's not the problem. The problem is people don't have the financial resources to access the healthcare system productively, and so they don't get the care they need, and then they go and tackle it a different way. And so, if you think about that notion of financial health driving healthcare costs and the problems in our healthcare system, then you lay on that the fact that employers are paying for those healthcare costs and they want inclusive and diverse workforces, right? An inclusive and diverse workforce. I've heard the phrase, if you're a woman or a person of color, you have to work 3 times as hard just to stay even. Well, think about the facts we just said about financial stress. If I'm going to miss 20 more work days a year because of financial stress, if I'm going to lose 13 IQ points at work because of financial stress, if I'm going to be sicker and less healthy and not getting the healthcare I need because of financial stress, then how am I supposed to perform as well at work, right? I think if you're an employer, you got to say, I got to tackle this issue of the financial health of my employees, and it will disproportionately, in a good way, affect women and people of color differently, because their financial situation, as the first session that I outlined, is just outrageously different.
Thank you. We have time for one more panelist to share thoughts. So April, I want to give you the final word before we close out.
Thank you. I appreciate that. So I think that this question of equity, unfortunately, what's going on in the world is affecting people of color and women at tremendously higher rates than others. I think that it's imperative that we all take some responsibility for ensuring that our organizations are clear about what they will and will not tolerate, first of all. And I think we have to go as far as being anti-racist, not just following the rules, which allows the system to continue. Secondarily to that, though, and as importantly, we have to offer support and programming that will address the caregiving stress, that will help address the financial stress, that also promotes for the individuals that are the employee the kinds of support programs that they need in order to get them through what is probably the most difficult time we're going to have, certainly in this decade, if not significantly longer than that. And so it's super important to make sure that you've shored up your benefits offerings, people know what they have access to, and to the extent that you do have to make difficult decisions about your workforce, make sure that you're communicating about what's available to them in the community.
Well, like at the award shows, we're getting the playoff music. So we thank everybody for paying attention. Thank you to our panelists for providing such tremendous insight. Thank you all for your leadership. And thank you all in the audience for joining this journey with us.
Thanks, Matt.
Thank you very much.
Good day, everyone. I'm Sarah Gordon, the Chief Market Development Officer at the Financial Health Network. I'm so pleased to be joined by Dr. Bashara Shukair, Senior Vice President and Chief Health Officer at Kaiser Permanente. Dr. Shukair was named by Modern Healthcare as one of the 50 most influential health executives and a top 25 innovator in healthcare. He's the author of a new book, Precision Community Health: 4 Innovations for Wellbeing. And I'm a particularly big fan of his, given I lived in Chicago while he was the commissioner of the Chicago Department of Public Health. And I watched up close all of the great things he did for our city, particularly for our most vulnerable residents. For those of you who are watching, as you listen, please add your questions to the chat on the Emerge Live page. We will be monitoring and we'll do our best to address them toward the end of our session today. Dr. Shukair, I'm going to call you Bashara, if that's okay. Welcome to Emerge Live. Thank you so much for being with us today.
Thank you, Sarah, for having me join this conversation. I'm so excited being here. It's an honor.
Excellent. So you've worked in healthcare and public health your entire career. First as I believe, family physician, and then later as an administrator. I'm curious what drew you to healthcare initially?
Sure. So thank you, Sarah, for the question. I grew up in Lebanon in the midst of a civil war, and I always had this idea that if I become a doctor, I can really change the world by treating patients in my practice. And so when I emigrated to the United States, I trained in a healthcare for the homeless program in Houston, Texas, as part of the Baylor College of Medicine residency programs there. And very quickly, I realized in my training as a family medicine resident or in my practice in Chicago 3 years later, I've realized that when you're really working with people living in poverty, people experiencing homelessness, all what I've learned in medical school and residency is good, but it's not nearly enough to help people live the lives that they'd want to live. And I very quickly realized that to really support people to live the lives that they'd want to live, it's a lot more than just healthcare. It's also about housing. It's also about economic opportunity. It's about legal protections. So I had the opportunity to work for a human rights organization based in Chicago, did some work globally in post-conflict zones. And then I had the amazing opportunity to serve as the health commissioner for the city of Chicago and Rahm Emanuel's administration for about 5 years. And I got to see firsthand the important role that public health plays in advancing the health and well-being of people. And that's really what draw me in. That's what keeps me in.
That's excellent. And we are definitely going to get into those intersections and how health is about so much more than medicine and our healthcare system. So, but you're now at Kaiser Permanente, and for our viewers who may be less familiar with the organization, could you please give us an overview of the org and your role in it?
Sure. So Kaiser Permanente is the largest integrated health system in the country. We have been in existence as an organization for about 75 years, and we have about 12.4 million Kaiser Permanente members who trust us with their care, trust us with their coverage every day across our footprint in the United States. And as an organization, we've had the same exact mission since we were born. So we're about improving the health and well-being of our members and improving the health and well-beings of the communities where our members live. And if you think about it, those are really truly go hand in hand. So there is no way we can improve the health and well-being of our communities if we don't really focus on the health and well-being of the 12.4 million Kaiser Permanente members that we work and engage with every day. And at the same time, there is no way we can optimize the health and well-being of our 12.4 million members if we're not investing deeply in the health and well-being of the communities where those members live. And when we do that, when we focus on the health and well-being of our communities, not only will we be lifting up the health and well-being of our 12.4 million members, but really all 68 million people who live in those communities. So as an organization, that's really what we think about day in and day out. You know, our 200,000 plus colleagues, our 23,000 physicians who are part of that group, we wake up every day thinking about what can we do to lift up the health and well-being of our members and our communities. And my role within the organization as the chief health officer is being that advocate that's constantly thinking about what else can we do? How can we improve the health and well-being of our members better, as well as the health and well-being of our communities? And so that work focuses anywhere from focusing on the 1 million plus Medicaid members that we take care of, and more of the duly enrolled members in Medicaid and Medicare, to thinking about our work on the social needs of our 12.4 million members. How do we make sure we're meeting their food insecurity needs, their housing needs, their transportation needs, but also looks at the health and well-being of communities overall, which goes into the core of what we'll be talking about when it comes to financial health and others in our communities. And I also oversee our environmental health portfolio and environmental stewardship portfolio for the organization. So it's a pretty broad portfolio, really
big role, yeah.
on really the core concept or spirit, if you want, of health overall, total health for our members and our communities.
So as a healthcare provider, as an insurer, as someone who is so focused on the needs of the community, you've really been in the eye of the COVID-19 storm. And I'm curious what the past 3 months have been like for you and your organization.
Well, it's been definitely different than anything we've ever experienced as an organization. And honestly, the whole world has experienced. You look at, the last 100+ years, this is one of the most significant public health threat that the world is dealing with. And the reality is, what we know about pandemics, we've learned from previous pandemics. So for someone who served as health commissioner for 5 years, probably the one thing that kept me up at night during those 5 years is the possibility that we might have to deal with a pandemic. And, I dealt during my tenure in Chicago with H1N1, with the Ebola crisis, with all other issues, but really nothing at the scale of the pandemic that we're dealing with today. So as an organization, the moment we've started realizing that this pandemic is not just going to be contained only in Wuhan, it's going to come to the United States, we really need to start preparing. We've activated as an organization across every step of the way to try to see how can we do more to be able to support our members, support our communities. Very early on, we were really working very closely with local public health departments on containing the pandemic when it first hit our shores. We've engaged with local health departments, we've engaged with state health departments to see what can we do to support that effort to contain that pandemic when it first hits our shore. The reality is very quickly we started seeing community spread, and we shifted into what we called a mitigation phase, where we had as an organization to step up and be ready for the significant increase of numbers of patients who are showing up in our emergency department, people with COVID-19 who needed to be hospitalized, people who needed to be in ICU, on ventilators. We had to step up and work very closely with our labor partner to make sure we have enough protective equipment to support our and really keep our labor, our employees and healthcare workers safe. We've worked with state and the federal government on ensuring that we have access to all what's needed to support the surge that we've seen back in March and April. And then we started seeing a decrease. So we started getting ready to go into this next phase of the pandemic, which is about suppressing the pandemic, getting back to doing the contact tracing, the testing, the isolation, the quarantine. And then now, unfortunately, as many of the social isolation measures have been lifted across our footprint, we're starting to see another increase in number of new cases, number of hospitalization, number of ICU bed utilization, which gives us a little bit of concern. So I think this pandemic is still, and we're still in the midst of the pandemic. I know we are, and we have to continue to double down on our efforts to keep protecting our members and our communities.
Yeah, you've certainly been incredibly busy, and we appreciate you taking the time for this conversation. But I think the pandemic really highlights the importance of so many of the issues that you've been working on your entire career. And I want to go to the book, right? Precision Community Health: 4 Innovations for Wellbeing. I just recently finished reading it. I loved it. It was incredibly well written and compelling, and it was a really fast read, I think, because of that. And I learned a lot, and I loved all the stories about Chicago. Without spoiling it for our audience, I would love for you to explain what you mean by precision community health and how you believe this approach will promote equity, right, and improve the lives of our most vulnerable community members. And if you'd like to talk about how this approach is especially important with COVID.
Thank you. And I have to tell you, Sarah, I never ever thought I would write a book. And then I immigrated to this country. I got to live in Chicago. Chicago became my home, got the honor to serve as health commissioner for this beautiful city. And so I changed my mind. And I think that at the core of what this book is about, it's really to say and be really clear that the community health, public health is really at an inflection point in our history as a country and as a world. And for us to be able to really be effective in creating better communities, better environments that are more suitable for people to live healthier lives, to be able to achieve their dreams and achieve their potentials and what they'd like to achieve, we have to be thinking beyond just what a healthcare system alone can offer. Healthcare is so critical, and yet it's just not enough. We have to be able to focus on communities that are most impacted, focused on people who are most disenfranchised, and think about the types of interventions that would support these folks with that equity lens, so we can lift up people who need the most support, so you can lift up the whole community. And that's what this book tells the stories of. How can we do that when it comes to policies? How can we do that when it comes to data? How can we do that when it comes to leveraging media and education in a way that's really effective and pushes the limit? And equally as important, how do we do that when we get into communities, build community coalitions in a way that lifts up the assets of those communities? So what that book does is tells the stories along those 4 pillars of how we can have a precision approach to lift up communities so that communities can achieve their potential. So that's what this book is about.
Yeah, and like I said, everyone who's watching needs to go read it, and we'll provide more info at the end. You make this point.
One other plug here is that actually all the proceeds from the book is going to support a network that's called the Big Cities Health Coalition. It's a not-for-profit organization that brings all the public health leaders from across the largest cities in the country to come together and really advance public health in this country. And as you can say, and you can tell, no time is better than this time to let our public health leaders lead. So I'm so honored that they accepted to take all the proceeds from the book.
That's wonderful. It's really great. And your point about how public health and health is so much greater than, again, just the practice of medicine or our healthcare system. We've come to a similar conclusion on the financial health side as well, right? That it is about high quality financial products and services and helping our financial service companies get in the business, right? See themselves as being in the business of promoting financial health, but it's also a much broader system. And we're operating, people's lives are much more complex, and it's going to really require a multi-sector collaborative approach. But I do want to spend time on this intersection between health and financial health. The focus of this conference and my organization, the Financial Health Network, is financial health. And by that, we mean how individuals manage their finances day to day in a way that really helps people weather shocks and pursue the opportunities in their lives. And we see a lot of research that shows how health and financial health are interconnected. In our own US Financial Health Pulse, we found that those who are financially struggling are in poorer health, and those that are physically or mentally unhealthy report lower financial health, right? So it's this vicious cycle. And as we said, COVID-19 has really brought this intersection more into focus, that we're experiencing a public health crisis, but we're also seeing a severe financial health crisis. So I'd love for you to talk about how that intersection comes up for you in your work, and especially at Kaiser Permanente, where do you see examples of that intersection, and how are you working to address it?
Yeah, thank you for this great framing for this question that I totally agree with. And actually, I'm going to start the answer by reflecting on one of the very first patients I met when I started my residency training in Houston, Texas. We were at a shelter in Houston, and I just fully ready to talk to my patients, talk to them about the importance of colon cancer screening and all kind of other screenings. And I remember this one patient, we were sitting, it was a Wednesday night or something like that, and we're having the conversation with this person, and I was telling him about how important it is that now that he's over 50 to get a colonoscopy to screen for colon cancer. And I kept and he wasn't just interested at all. And I kept coming back to this topic. And then maybe 5 minutes down this conversation, he looked at me in the eye and he's like, dude, what is it you don't get? I'm not worried about potentially getting colon cancer 5 years from now or 10 years from now. What I'm worried about, do I have enough money in my pocket to get my food tomorrow and potentially be able to put a deposit on my rent so I can get into a place so I'm no longer sleeping at a shelter? And to me, the story is always front and center to my mind. And the more I progressed in my career, the more I've realized, and I've seen it head on, this connection between financial health and health overall. We know from surveys after surveys after surveys that there is a direct connection there. I mean, think about the top 1% earners in this country and the people who are in the bottom 1% of income in this country, and you look at their life expectancy, there's a 12-year difference. So if you're in the top 1% richest people in this country, you're expected to live 12 years longer on average than if you're in the bottom 1% of the income in this country. And we've seen that also in surveys. Just last year, we've administered a survey, and that's before COVID-19 hit. And what we've randomly selected a representative sample of people in this country, and 68% of these people have experienced at least one unmet social need in the prior year. And 1 in 4 people have experienced a social need that was a barrier to health. So we know from that survey that 21% of people living in this country had to prioritize buying food or paying rent over getting the healthcare that they need. So the connection there is crystal clear. We've also seen, when we've asked those folks that we've surveyed, and what we've realized is people with social needs are twice more likely to categorize their health as poor compared to those who don't have those social needs. So the reality of the connection is right there. It's so straight. There's no doubt about that. So as an organization, we've been thinking about what's our role to support our own members with their financial health, as well as what do we need to do within the communities to create better environments for financial health. And I'm happy to go into examples if you'd like me to do that, but that's the framing I think is so critical.
I absolutely want you to go there, and apparently so does our audience. We got a question saying, Kaiser member here, what specific initiatives are you looking into to improve your members' financial health? So I would love for you to speak about kind of on the business side and your support of members, but also those broader initiatives in the community as well.
Yeah, so let me take one, and we have, by the way, many examples. So let me start with one concrete examples on the member side, and then I'll give you one concrete example of our work in the communities, because I think those go hand in hand. In our surveys of our members and our engagement with our members, we've heard repetitively from many of our members that they are having financial challenges to even be able to buy the food that they need to be able to live healthier lives. I mean, just not have enough cash to buy food, and food insecurity becomes a significant issue that's directly tied to financial health. And so when we started engaging with our members, we started this process a few months back. And now in post-COVID, we're realizing how many of our members are facing even more financial strain. They're needing more support with access to healthy food. So we are partnered with a couple of organizations, and now we're engaging with our members and those members who qualify for food stamps, but they don't have it. So we're engaging now with those members in multiple ways, by text, by phones, by directly engaging and supporting them along the way. And we have already over 45,000 members who've completed applications to be able to sign up and get food stamps. And that's about, $150 to $170 per month extra that those members will get into their pocket to be able to spend in their local grocery store so that they can put at their dinner table. So that's one example of how we're thinking about that. On the community side, we've also realized that there is a big role we can play to support small businesses, particularly Black-owned or other minority-owned businesses, women-owned businesses, veteran-owned businesses, LGBT-owned businesses. So we've partnered with organizations, and we've hosted multiple cohorts across our footprint of literally over 1,000 of those small businesses over the last couple of years across all of our footprint, to support these cohorts with the right coaching, the right mentorship, the right business planning development, access to capital so that they can be able to grow their businesses. And we've seen these businesses grow significantly, adding more jobs, adding access, having more capital to do business, and being able to be of a size big enough to be able to do business with Kaiser Permanente, which as an anchor institution, we spend billions of dollars in doing business with organizations across the country. So by having those cohorts, we can really double down on our commitment to purchasing from minority-owned businesses, women-owned businesses, and we've done that to the tune of about $2 billion every year now. So those are two concrete examples of how we're engaged in this work.
And I've seen you present before, and I know sort of individual financial health building is increasingly on your radar. And I know it's, the primary topic that our audience is coming together to explore. Anything that you have in development or that you're thinking about, or how are you starting to view? I think the small business piece is really critical from an economic opportunity, and we've done a lot of work around small business owners and how the business's financial health and the individual's financial health often gets conflated. But as you think about your members who are struggling to pay their bills, or who have limited savings or credit, right, that they need to rebuild, have you thought about how you might start to approach some of those challenges?
So a couple of things to keep in mind. One, we're actively looking, and we're not ready to announce yet, but we're actively looking into what type of products or services our members could benefit from when it comes to their own individual financial health. We're working on that. It's not ready. It's not ready yet, but we're realizing, to your point, quickly and more every day, that if we want to think about the health of our members overall, we can't just be thinking about their physical health or their mental health. We have to be thinking about their social health, and their financial health is an incredibly important aspect of their social health. We've heard that directly from our members. We know that from the research. So more to come on that front. At the same time, we also realize that many of our members have challenges being able to meet their copay, their deductibles, their coinsurance, and so we have robust programming and planning within Kaiser Permanente, where we're offering literally hundreds of millions of dollars every year in medical financial assistance to members who we know are struggling with their financial health. So whether you are up to 350 or 400% of federal poverty level, we've put systems in place to be able to support you, whether you're our members, or honestly, even if you're not our member, when you're accessing services through that system. So continuing to enhance our ability to support our members when it comes to affordability is critical. And now in the COVID pandemic is even more critical. That's why we've waived copays, we've waived testing costs, we've waived cost sharing from the overwhelming majority of care related to COVID as a result of this pandemic. So more to come on that. This is an emerging space that my team is spending lots of time and energy, and would love to keep you all posted as this continues to evolve.
Yeah, we're excited, and also to sort of be a partner in that, and I think our network here, right? We're all rooting for you to sort of figure out the best strategy and approach for your organization as it relates to individual financial health. I'd love for you to talk a little bit, and maybe it's self-explanatory, but how are you starting to think about the business case for some of these efforts, right? That really kind of get at improving financial health security, economic opportunity in your communities. Is this, is it really of critical business importance? Is it really the clinical importance, or is it really moral importance, right? As it ties to your mission as an organization, or maybe all of the above?
Yeah, it honestly is all of the above, Sarah. I think when you look at the financial health overall, and you start carving out the components that are even more closely related to total cost of care and outcomes, part of the reason why we're spending so much time on food insecurity, which is, you're food insecure because you don't have enough money to be able to buy food. I mean, it really is directly connected to your financial health. Part of why we're spending so much time and energy there is because the business case is a lot clearer there. We know that if you're food insecure, your chances of being your total cost of care is higher than if you're food secure. So it just makes total sense for us to be actively engaged with you to make sure that we're addressing your food insecurity issues. We know that if you don't have enough money to buy food and you're a pregnant woman, chances are you're going to go and get into preterm birth or have a low birth weight baby. And we know that's directly tied to your total cost of care. We know if you're hospitalized and you're being discharged from the hospital and you can't afford the food that you need after you're being discharged, chances are you're going to be readmitted to the hospital are 50% higher than if you have the money you need to be able to buy your food. So it becomes a lot clearer on certain aspects of it. But I think overall financial health is so directly tied to physical health. I think I've mentioned this, the statistics earlier. If your life expectancy, the difference in life expectancy between the richest 1% and the poorest 1% of Americans is 12 years. That's 12 years lost of somebody's opportunity and chance to live the lives that they'd want to live. We know that the household wealth gap between Blacks and whites in this country is significant, and it's growing. We know that by 2053, we expect the household wealth of a Black family is going to go down to zero. By 2073, for Latinx family is going to go down to zero at a time where those numbers going up for white communities, so for white families. So I think the direct link between financial health and health is so crystal clear in our mind. And that's why we're in this, honestly, that's why we're in this business as well with you and others to help us figure out what's the right way to support our members and our communities in this space.
So the title of this session was After the Pandemic, and I think you pointed out that the reality is that we're still very much in response mode to a first wave, and we're continuing to see increases in over half of our states. But that said, what do you think the greatest lessons are going to be from this moment, and where do you see, what's it going to take really to achieve your vision for being the precision community health and achieving health equity, and to ensure that we're able to tackle some of these really intractable problems?
Yeah. So I think 3 lessons I'd want to lift up here in the last couple of minutes that we have together from what we're learning from this pandemic. And to your point, we're still in the midst of the pandemic. Just a reminder for everybody who's here, please use masks. Please avoid going into places if you don't absolutely have to do that. Keep your social distancing. All those are really important parts of our tools, if you want, to help us suppress this pandemic. But 3 key, I think, lessons for me. 1, this is the time to let our public health leaders lead. This is not time for politics. We need to double down on the importance of letting the public health leaders in this country and in the world lead. So that's a key message. The second takeaway, I think, for me is, the pandemic is not just a public health crisis. It's also a financial crisis, and we have to think about how we balance the response to both. I think I've seen over the last few weeks, and particularly a big push to try to put these as opposing each other, and the reality is they're not. Like, we need to figure out how we're bringing the public health community, the financial community to work together to help us recover from this pandemic that's crisis on both fronts. And then the last piece, I think, to me, is the most critical piece. I think we've seen the disproportionate impact of this pandemic on people of color in our communities and across the country. And as we're thinking about the recovery, we have to be thinking about how that recovery is done in an equitable way. We want to make sure that we're supporting people who are mostly impacted by the pandemic at all different levels and lifting them up so we can have an equitable recovery. Because if we don't do that, we're going to get at the other end of this pandemic with a more inequitable community, more inequity, and further away from social justice. And I'm hoping that this is the time that it's an inflection time to get us all moving towards equity, towards social justice. And I'm hoping that everybody will be in this together.
Me too. Dr. Choucair, thank you so much for joining us today and for your vision and your leadership. We look forward to continuing the partnership with you and your team to write what I hope is like the next chapter of your book on how we can really work collaboratively to address the financial health challenges of your members and in our communities as a way to ultimately improve health outcomes. So for those in the audience, please watch for the info about where to get Bashara's book. And if there's anyone listening who any healthcare providers who are really interested in working around this intersection, we would love to hear from you. So thank you so much. Have a great day.
Thanks, Sarah.
Hello, everyone, and thanks so much for joining us for day 3 of Emerge Live. As always, I hope you found today's content engaging and that you're planning to come back tomorrow. As we wrap up for today, I'm joined by my colleagues, Matt Ball, Vice President of Workplace Financial Health, and Sarah Gordon, our Chief Market Development Officer. Matt and Sarah, you both moderated some terrific sessions today. Thank you so much for participating. I'd love to hear from both of you on the themes or ideas that really stood out to you today during our discussions on the connection between health and financial well-being. What stood out for you and why? So Sarah, we'll start with you.
Sure, thanks, Laura. It was a really great day. I thought our speakers really helped us appreciate and sort of unpack this connection between health and financial health. And how, all of this has been more illuminated thanks to COVID-19. And I also really appreciated the directness in some of the conversations about how systemic and institutional racism have contributed to disparities in both health and financial health, right? That, if we're really committed to overcoming that, it's going to require a multi-sector approach. And I think there were moments when, it was easy to feel like all hope is lost, or right, that these problems are so big and gnarly that, what's the point? Change will never come. But we heard from so many leaders and innovators in our hospital systems, in our insurance companies, the new entrants, right, that Matt spoke with, where I saw they gave me reason to be optimistic. And I think it was a really good reminder that all actors have a huge role to play, and that we can't be overwhelmed, we can't be paralyzed and not figure out where to start. And I thought the comment on the early morning panel is that we just have to start by using the tools we have. And I thought that was so powerful, that whether that's if you're a policymaker or you're in the media, or if you're an HR professional, or if you're, developing financial products and services, that, we can all start somewhere. And if that's still not enough, you can start with the fact that we have, we can listen. We can all find ways to listen to our communities. So I thought it was great, and curious what Matt thought.
Yeah, I would certainly echo a lot of your sentiments, Sarah. I think for me, what was really interesting was the process through which we were able to excavate these two large, complicated systems of financial health and start to really see how they're tethered together in unique and interesting ways. And they have in many ways a symbiotic relationship. But at the same time, I felt all of our panelists were able to recognize the system's complexity, but always make it about the individuals and the humanity who have to navigate through that incredibly complicated web. And so to me, I thought there were a few quotes throughout the day that really highlighted the humanity of the sessions today. One was from the first panel, which is, we haven't changed, nor are we going to change systemic racism with philanthropic dollars. It will take a multi-sector approach. Another one that I thought from the last session was lift up the assets of communities. And what I hear through these two, I think, critical takeaways from today's sessions are that these systems are complicated. There are opportunities to solve points in time challenges, but we have to constantly be digging deeper to find ways to make it easier for people to access, navigate, and utilize these systems. And that may require systems change. It may require deepening of integration. It may require new ways of thinking and innovation in order to truly provide a more beneficial system for all, and not simply those who are able to be in a position to afford their way through that system. So I thought, to me, it was really insightful. And not that I'm biased, but frankly, this was a different type of conversation I thought that we hosted today about these intersections that was not just focused in a particular band, but had a breadth and depth that I think is really useful for people interested in this topic.
Yeah, and I'll point out, I mean, this was our first full day of content around how health fits in ever in the emergent sort of history. So I thought it was great, and hopefully everyone sort of appreciates the broadening that's going to be required to really achieve financial health for all.
Yeah, I would agree. And I really appreciate you guys joining me to outline some of those themes. I certainly heard a lot myself. I think this integrated system idea is starting to become quite clear. We've heard it today. We heard it the last couple of days. So really, really thankful for you guys coming on and giving us your reflections. So as we wrap for today, I just want to remind everybody that we will be back here again tomorrow, 12 noon Eastern Standard Time. Tomorrow's theme addresses topics around rebuilding resilience, and we're going to be talking about the role of retirement, the role of emergency savings platforms, and other opportunities that we have to really help our communities develop ways to build and thrive, particularly through through moments of challenge. And so I really welcome everyone to come back tomorrow. I want to just say a big thank you to all of our speakers from today. It was terrific, and all of our moderators, but also again to all of our sponsors who have just been so incredible in supporting us to continue having these conversations. So we hope to see you back tomorrow, and have a great rest of your day.